And now I'd like to introduce our first presenter. Her name is Elena Frank, and she's from Upstate University Hospital. Elena Nam is a genetic counselor at SUNY Upstate Hospital Department of Neurology. She provides genetic counseling and testing for children and adults in New York State with special focus on epilepsy and neurodevelopmental conditions.
Good morning. My name is Elena Frank. I am a genetic counselor at SUNY Upstate Neurology in Syracuse. I'm here today to talk a little bit about how epilepsy genetic testing is conducted, kind of the what, why, and how for getting genetic testing for epilepsy. So a little bit first about this person that's telling you what to do and how to do it. I'm a genetic counselor, like I said, at SUNY Upstate, and I have been here since 2022, straight out of school. I am a CNY native, so I am originally from this bright green star way up north in New York, but before I returned to Syracuse, I did a little foray into the University of Pennsylvania, where I trained at the Children's Hospital of Philadelphia in their Epilepsy Neurogenetics Initiative clinic while I was getting my master's degree in genetic counseling. And you might see here, I've got my alma mater, my undergrad in RIT, so I've been all over the state and happy to represent today. So what even is genetic testing? Before we get into how you would get it, let's think about what our genes are and what we're looking for on the genetic testing. Every single one of us in all of our thousands and thousands of cells in our bodies have 46 of these chromosomes. These chromosomes are packages for our genes. They're really tightly coiled, containing lots and lots of genes per chromosome. So we have well over 20,000 genes in each of our cells. And these are almost like the words in our instruction manuals. These genes are telling our bodies what to create and what to do with what it creates so that we can carry on in our lives. So when you look for genes, you're almost uncoiling this chromosome here and looking at each individual word in the instruction manual, which looks like little beads here. In real life, they're not nice round little packages like this. They're actually also coiled up strands of DNA. DNA is like all of the words combined in our instruction manual. It's the piece that we need to understand to read. And the reason that I compare genes to words is because if you zoom in even further on those genes, you'll see each of these individual bases, these letters down here at the bottom. Bases are represented by letters. These letters mean gibberish. They're not going to line up into nice words that we would understand in English. But in the genome, in all of our genes put together, these mean very important things. So if we look to the right side of the screen here, you can see that these spellings, T-A-T, C-A-T, C-C-T, are always three-letter words. And each of those words tells us how to make a certain protein. This is getting pretty granular. We don't need to know what each of these proteins under the arrows mean. But a good way to think about them is that they each have their own shape, like a puzzle piece. So as we follow these instructions for creating proteins, if we spell one of those words wrong, we have to think about what that means for the puzzle piece that should be created. So these next three categories show us different types of genetic variants. You might recognize a genetic mutation more closely. We prefer the word variant because not all of them mean that the shape of the puzzle piece is going to be changed. But for our purposes here, let's talk about what happens when we do have a variant that changes the shape of the puzzle piece. Sometimes we swap out one of these letters. So right here where we're supposed to have a C, instead the body created a G. It's hard to say why it created that G, and we can get into that more later. But even though CCT stands for this pro shape right here, CGT makes a completely different shape, this arch shape. And that puzzle piece does not fit into the puzzle pieces around it the way that pro does nicely. If we were to add a letter, almost like you're typing and your finger accidentally hits an extra key, then that bumps the next C out of the way. So now where we used to have CCT, we have CGC in our 3-letter word. We pushed that T into the next section of 3-letter words, and now we get TAA, and we actually have a little extra letter right here. CGC also makes an instruction for this ARG protein. We can have different combinations of letters to make those proteins. And we know that that one doesn't fit over here with HIS. So that's going to be a problem for us. But even more, now that we've changed the last 3-letter combination, this TAA actually tells us to stop making protein altogether. That is a stop codon. So if there were more 3-letter combinations that came after this, we would lose all of them because we just told in the instructions to stop creating proteins. If we were to delete a letter, let's think about right here where we used to have CAT, we deleted the A. So now our combination of 3 is CTC. CTC makes this LU protein. It shifted all of the letters next to it. So now we have another LU protein and an ARG protein, and none of these fit very nicely together. So this is a combination of proteins that won't come together into a nice puzzle or a nice function or structure in our bodies like we need it to. So why is it important for us to know all of that complicated information that I have a whole master's degree just to understand? Well, have you ever asked why epilepsy is happening? Why do I have epilepsy? Sometimes the genetics can tell us why that's happening in the first place. In other cases, it can actually be helpful for knowing what to do about that epilepsy. Some specific genes, when they have variants in them, respond really nicely to a certain medication. Think about the fact that we know which puzzle piece isn't shaped the right way anymore. Let's help it do its job with this medication, or even replace that puzzle piece in some cases. When we know what the genetic cause of your epilepsy is, sometimes we can compare to other people that have had the same type of epilepsy, the same genetic cause of epilepsy. And we can say that, well, all of those people had epilepsy when they were kids that stopped when they were around 9 to 13 years old. That's just a really broad example. And we can't say that every person will fit into the box that we've created based on looking at other people. But it gives us a little bit of expectation, to a little bit of context to help guide our care going forward. In the same way, sometimes we can say most people with this genetic cause of epilepsy also have learning or developmental difficulties. More people with this type of epilepsy have unfortunately experienced SUDEP, that sudden unexpected death in epilepsy. So this tells us a little bit of what to watch out for based on the population of people that have had the same condition. If we know that there's a genetic cause of the epilepsy, we can also start tracking it through the family. Now, some of us end up with a genetic variant all by ourselves. We didn't inherit it from mom or dad, even though we get all of our genes from them. Think about a little elf at the time that a baby is made, typing all of those instructions from dad and from mom into this new baby. If they're typing really, really quickly, they might make a mistake. They might hit an extra key in there or hit the wrong key or miss a letter. And so sometimes this happens completely randomly and isn't something that also came from mom and dad. But if it is something that came from mom and dad, that means that any other children of that mom and dad could be at risk to have the same condition. For the epilepsies that start later on that aren't present right at birth, it might be helpful for us to test that baby and know that they could have seizures in the future, just so that we're watching them more closely. Or some people might choose to try to have a baby that doesn't have that genetic condition. And some of that is possible through in vitro fertilization and genetic testing before the pregnancy is even conceived. And then lastly, kind of my favorite part and the reason that we're all here today is if we know what group of medical conditions you fit into, you can find other people and make friends with them because they're experiencing the same thing. For us, we get this awesome group of people that all have epilepsy. When we find a genetic cause of that epilepsy, if it's a specific condition, we can connect with other people that have that same specific condition and understand people that have even more similar experiences to us, right? We all have very different types of epilepsy, different experiences with epilepsy. So sometimes it's nice to get together with a group that has a slightly more similar experience. It's like a subgroup. Now, not everyone that has ever had epilepsy has gotten genetic testing, not by a long shot. But we've tended to say as a genetics field that people who have seizures that start first thing in infancy, or that are really, really severe seizures, maybe really frequent, that are getting in the way of early development in babies, people that have seizures and learning or intellectual disabilities, people who have seizures and autism, all of these people are more likely to have a genetic cause of their epilepsy. But genetic epilepsies can present anytime, any age. They can look very different. They can be generalized or even focal. And there may or may not be other pieces there like autism or learning disabilities. And so at this point, recommendations are starting to be extended to every person that has epilepsy to get genetic testing. In fact, a new guideline paper was just published by an awesome group of genetic counselors last year who said, based on our experiences and the experiences of other people that we've spoken to, we're going to recommend that genetic testing for epilepsies looks like this. It's just a recommendation. It's not rules, but we as genetic counselors can use these recommendations to justify why and how we're approaching genetic testing. Sometimes we need to justify to insurance companies why we're ordering the test that we're ordering. So having a group of guidelines like this says, this is what everyone else is doing, and gives us a little more confidence that that's what's necessary. This paper started with 2 recommendations after all that they studied. The first is that everyone with epilepsy that hasn't already found the cause of their epilepsy should be offered genetic testing, no matter what age they are. And this is a little bit different from the way that genetic testing used to be considered. It used to only be offered to those people that fell into those groups I mentioned before, especially young people. And still, we have a little bit of trouble justifying to insurance companies that an adult with epilepsy should get some genetic testing, but this guideline helps. It says, without limitation of age. The second recommendation says we strongly recommend that genetic tests are selected, ordered, interpreted, done by a qualified healthcare provider in the setting of appropriate pre-test and post-test counseling. Appropriate provider doesn't have to be a genetic counselor. More and more, that's what it is. But doctors are able to order genetic tests, and other healthcare professionals that are able to order anything at all for you. The setting of appropriate pre-test and post-test counseling is a really important piece of this recommendation as well. This says that we think that there should be appointments, or at least time set aside, to talk to the people that are getting their genetic testing to help them understand what's this test for, to go through some of the things that I'm talking about today, maybe in less detail, maybe in more detail, based on what the patient would like to know about themselves, about the test, about what comes next. So doing that pre-test gives us the opportunity to say, what is this? And doing that post-test gives us the opportunity to make sure that all of the results of the test are well explained and well understood, so you don't get lost in the meantime. Now, in this paper, they also compared the benefits of different types of genetic tests. I, in my clinic, am primarily using these two highlighted options here, the multi-gene panel and the whole exome sequencing. And this is tending to be the trend for the genetic counseling field. We're straying away from microarray a little bit, and we don't really have access on a clinical basis to whole genome sequencing in all places. And I'll get into a little bit more detail about what these two tests are later on. How do we get this genetic testing? If I've piqued your interest so far with explaining all of what genes are and what genetic testing can do for us, here's what we start to think about for making this happen for ourselves. First, we need to know that epilepsy is there. You can't just say, I think I might have epilepsy, and look for a genetic test. We want a doctor's opinion in there too, that says, yes, we think that this is probably epilepsy. No, we don't think that it's anything that can look like epilepsy. Some people may be familiar with this, but sometimes when you have a condition that makes you pass out, like a heart condition, or when you have movements that are not necessarily controlled, like tics almost, sometimes those can look a little bit like seizures. So we need a doctor in here to make sure that we're testing for the right thing in the first place. And that doctor is the one that's going to make a referral to a genetic counselor. There are a few genetic counselors throughout New York State. You have your option to request referrals to certain genetic counselors. You may need to request from your doctor, well, I know that there's a genetic counselor in this area. Can you send me to that person? Then there's that pre-test counseling appointment that I talked about, where we talk about any questions the genetic counselor or the person doing the genetic counseling has after reading the doctor's notes. So we get the doctor's notes and see why they think you have epilepsy, but sometimes we still want to know a little bit more about your family history or how we came to that diagnosis. That's when we talk about what the options for testing are. We go through that list of 4 tests, and sometimes we'll reduce it down to those 2 preferred tests, and then talk about how we get the sample for the test. Usually that can be a cheek swab, or maybe saliva sample, or a blood draw. Continuing on through this process, we have the insurance authorization time. Sometimes that's happening at the same time as testing is being ordered, and you're seeing the genetic counselor kind of in the background. Sometimes that can be ordered by the lab that's doing the genetic testing too. So sometimes it's not your counselor that's processing the insurance side, sometimes it is. Then we're waiting for a test result to come back. And this takes longer than a lot of blood work does. We're looking at minimum 2 weeks for your results to come back. Maximum, I say up to 6 weeks. Sometimes I see it go as long as 8, and that's if we don't get held up with insurance in the meantime. So genetic testing can take quite a long time. After the test, generally the recommendation is to have another appointment to talk about the results. Sometimes you'll get a phone call or a letter with your results, especially if they're pretty easy to understand and you covered all of the details pretty well in your pre-test appointment of what to expect. But sometimes you'll have an appointment to talk about what those results were and to discuss if we need to move on to more testing if we didn't get an answer on that first one. Then the genetic counselor or the person doing the genetic counseling should pass that information along to your neurologist or the person that's diagnosing your epilepsy to say, here's what I found, here's what I understand for this person's care going forward, and what I would recommend based on these genetic test results. A genetic counselor isn't a person that's going to give you a new epilepsy medication based on the results, but they can tell your doctor, I would recommend that you try this medication if you need to change any meds. So if we condense that timeline down into one slide here, just into headings, I want to pull out a couple of these lines to focus on a little bit more deeply. In that pre-test counseling appointment, there's a lot for us to discuss there. I'm going to teach a bit in my pre-test appointments personally about genetics and about epilepsy, similar to what I've done here, although maybe not in so much detail. We're talking about why we're doing genetic testing, and I'm explaining why you're at this appointment in the first place. And then we're discussing, why would you want genetic testing? How do you feel about it? Because genetic testing is always optional. Remember, at this point, you've already been to a doctor and gotten a diagnosis or a suspected diagnosis of epilepsy. And lots of people have their epilepsy managed without knowing what the genetic cause of it is, if any. So we can absolutely do that for you. If you don't feel like genetic testing is going to benefit you that much, or if it's information that you don't want, then we can skip right over this. But you can have that appointment first to find out about it, to hear me out, right? I want to know what's going into your decision to be tested. Which of those possible benefits do you want? Do you want to plan for future pregnancies or for other kids in your family that don't have epilepsy yet? What would you prefer to know? Is this epilepsy something that came from my side of the family because everyone I know has had seizures? So how could this help you? And remember that this information can have long-term significance. So if we find a genetic diagnosis for your baby, they're going to have to learn about that information in the future, and they might want to think about it when they're having kids. So you're choosing for your baby right now to get some information that they may or may not want in the future. So let's think about whether you would want to give that level of information to your kiddo. And then also, are we considering any specific genetic conditions? When you come to me, I am keeping an ear out for certain notable words in your history. Does it sound like you have a specific type of epilepsy? Because generally there are certain genes that go along with that. Take, for example, seizures with fever, febrile seizures. So some people will not make it to genetics because when they only have febrile seizures, because the assumption is all of those seizures are caused by the fevers. But there actually are some genes that will make you more likely to have a fever, or I'm sorry, more likely to have a seizure when you have a fever. So I'm going to make sure that we're paying special attention to those genes based on our conversation ahead of time and knowing that you only have febrile seizures. I still think we should test, but I'm going to make sure that we're watching a certain subset of genes. Do I think maybe that there's another condition going on here? Should we be throwing on a test for something other than the epilepsy? Now, this is a slippery slope. I really only know how to talk about genetic testing for neurological conditions, but maybe I'll make a recommendation to a different type of genetic counselor, someone who works in cancers or in heart conditions, or I'll include that information when I send off your testing. We'll see if we find any genes, and then I'll send you to someone else to give more information about those genes if I don't feel like I can explain them well enough. All right, back to our outline. What goes into that insurance authorization piece? This is a piece that remains a mystery for many clinicians, many patients, and it's constantly changing. But what the genetic counselors tend to train themselves in is the billing practices of the labs that they use for their testing. So take me, for example, I've included a screenshot from the GeneDx website. That's just one genetic testing place that you can order from. I just picked a couple of random ones here. There are lots and lots of options for us and lots of things going into considering which to do, which to use. The GeneDx website uses this patient billing page to explain what a patient should expect. So they say your healthcare provider places the order and GeneDx, the lab, places the prior auth request from the insurance company. So they tell the insurance company, we're about to do this test. You should, start considering whether you're going to pay it. They continue doing the testing at the same time. So they aren't delaying your test results coming to you based on the insurance company taking a while to decide whether they're going to cover this. Sometimes that means that we finished a test and now someone has to pay for it and the insurance company has said no. So that's something to be prepping yourself on ahead of time for the genetic testing. Sometimes we can do what's called a benefit investigation. So we can say ahead of time, I'm going to order a test for this person. This is the one I'm thinking of. If their insurance company says yes, that we can have it, how much are we expecting that it's going to cost for them after insurance kicks in? That's just one lab's practices. Another likes to tell us that with insurance, usually you're paying less than $100 for your testing. So that gives us a little bit of a threshold to prepare for in case the insurance does deny. We can say, well, we expect that it will probably be under $100 anyway. And they list out here how billing through a private insurance versus a Medicare versus a Medicaid. There are also very often patient assistance programs. So that's based on your household size and how much income you have. They may reduce the price of the testing even after insurance kicks in. So this is lab by lab, and sometimes you'll have to work with your genetic counselor to decide which lab to order the test from. This lab, Invitae, and the other lab that I mentioned, GeneDx, both have an epilepsy panel. If they both contain similar genes, let's talk about which one will fit your billing availability better. There's a lot to go into that conversation. It's very personalized. And back to our outline again. Let's talk about what the actual testing involves. I mentioned that in the pre-test appointment, we're going to talk about those different genetic test options for you, including which lab to order from, how many genes they have on their panel. My standard is around 300 genes on an epilepsy panel. So there are about 300 genes that we know currently can cause epilepsy. Some labs may feel that only 200 of them are certain. So we're only going to show you those. And some labs may feel we want to include the genes that might cause epilepsy, but we don't know yet. And they might offer 400 genes. Now, these are the panels. This is a selection of just the words from your instructions that, if they're spelled wrong, could cause you to have epilepsy. A whole exome sequence, that other one that I tend to favor, is 20,000 genes, all of your genes. And we're pulling out just the genes that have variants in them, and then filtering that list even more to tell you about the ones that could fit your symptoms, so that could fit epilepsy. And that's because lots of us have genetic variants that don't ever cause us any issues. They don't cause us to ever need medical attention because they're benign variants. On a whole exome sequence, you could end up with lots of benign variants or ones that we're not sure if they're benign yet. So we need to tell you about reducing that down based on your symptoms. So these two tests are almost like spell checking your genes. We're looking to make sure all of the letters are in the places that they're supposed to be. Other genetic tests, like a chromosomal microarray, I didn't highlight this one in our previous list, but that looks for whether you have sections of your DNA missing or duplicated. That would be like accidentally typing one line in your instruction manual twice, or skipping right over a line as you're typing it out. And those instructions don't really make sense anymore. And there's not really anything wrong with the words there. They're just not there, or they're there twice. The whole exome sequence in some labs will cover missing and extra sections of chromosome as well, where the panels are really just spell checking for us. They're just looking at the individual genes. And then, of course, it's the genetic counselor's job to understand, how reliable is this lab? What do they like to report? Do they tend to call things positive when we're mostly certain or only when we're very certain? How are their billing practices, like we discussed, and how big are their panels? And then in that post-test counseling appointment, what are we talking about there? Well, what did we find on the genetic test results? And there are a lot of different things that we can find there. This is not just, yes, we saw something, or no, we didn't. And that would be a positive versus a negative result. And we do get those sometimes too. Positive result is when we see it pathogenic, a positive variant that we know interferes with the gene's ability to do its job. And we know that when the gene can't do its job, the person will have epilepsy. The negative means that out of all of the genes that we looked at, we didn't see any variants that could explain your symptoms. For a whole exome, that means maybe we saw variants, but none of them cause epilepsy or the type of epilepsy that you have. Sometimes we'll fall in between those two results. We'll have an uncertain result. A variant of uncertain significance means that we see that the spelling of the word has changed, but we don't know what the shape of the new puzzle piece is. Maybe it looks the same and still fits into the other puzzle pieces. And so we look for other people that have similar, or that have the same, variant of uncertain significance and say, do they have epilepsy? Do they have similar symptoms to my patient? If so, then maybe this common thread between everyone is what's causing their epilepsy. Then over to the right here, these two options can come up on any test as well. They don't really mean anything for us in terms of current clinical care. That means it's not answering the question as to why we have epilepsy or what we do about it. An incidental result means we might have to start some medical care for a condition that we weren't even testing for in the first place. So heart conditions are a good example of those sneaky ones that we weren't testing for this, but sometimes we see that gene that we're looking at for epilepsy isn't changed in a way that causes epilepsy, but is changed in a way that affects your heart rhythm. The charges in our brain, those fiery electricities that we measure on EEG, those are the same charges that happen in our hearts to make them pump. And so heart conditions are really the one that we're prepared for a possible unexpected result there. And then carrier results. This means that we have one positive or pathogenic variant in a recessive gene, which means that the other copy of the gene is still working just fine and we're not going to have any symptoms. Recessive conditions only happen when we knock out both copies of the gene in a cell. Remember, we have 2 copies of every chromosome and 2 copies of all of the genes that are on them in every cell. So a recessive result, a carrier result, doesn't mean that you have a condition right now, but it means that if you have children in the future, they could inherit that recessive variant from you and also could inherit it from their other parent and end up with the condition, have both copies of that gene knocked out. So it's more of a future preparation consideration. Any of these results could warrant some further testing, especially though the negative and the uncertain. If we don't find an answer for why you have epilepsy on a panel where we've selected just some genes, maybe we should look at all 20,000 of your genes and keep digging. And then finally, this clinical correlation piece. What are we telling the doctors about your genetic test result? And what are we doing next? A positive result might give your epilepsy a name. We might say that you have, for example, tuberous sclerosis. That is a condition that can cause epilepsy. And maybe that condition has some other follow-up recommended. Maybe that can affect other organs too, and we should have those checked out. Or maybe it just tells us why you have epilepsy. An uncertain result may require some more testing, like I mentioned. Maybe we have to test mom and dad of the person that have an uncertain result to collect more information about whether this is coming from a person in the family that also has epilepsy. Or maybe we need some non-genetic tests to figure out if this is a reasonable result for the patient. Maybe if we look over to the right here, we have to tell the doctor that this person has a gene that goes with a disorder that's treated well by a certain medication. So these KCNQ2s are potassium channels. So if we turn up the potassium activity in those channels, we might be able to get control of the epilepsy. Sodium and potassium have to play together. So if we need to turn everything down, maybe we can turn down your sodium and the potassium will lower itself down together. That's one example, and there aren't a lot of genes that can cause very clear medication recommendations to be made like this, but they're worth taking into consideration when we do find those. The neurologist is ultimately the person that decides whether you should have any medication changes or whether you should go to another provider for other checkups. You should still follow up with the neurologist per their recommendations. The genetic counselor isn't now going to take over epilepsy care. They're going to tell the neurologist what they would recommend, and the neurologist does what they think is appropriate based on their medical training. And that is the broad strokes of genetic testing. I'm going to open up for questions now. I'm happy to take any questions about everything that I've covered here or things that you wish I had covered. Before I do, though, I want to thank the Epilepsy Coalition of New York State for having me on today. It's been a real pleasure to work with this group and to be able to talk with all of you.
Thank you, Elena. That was great. And we are very honored to have her on the call live right now to start taking some questions quickly. We have some time in our schedule for some of the questions that came in. And Irene Rogers, who is the Chief Development Engagement Officer at the Epilepsy Foundation Long Island, is going to pull some of those questions off the chat and ask Elena right now.
Elena, thank you so much. Oh, my goodness, such an interesting but complex topic. And clearly you have struck a chord because we have a number of questions, some that you may have answered while you were presenting. But, we had some people coming in after you started. And also too, I know myself, I need to hear information a couple of times over before I can truly take it in. So we'll just start with the questions as they have come in. Okay. So how long has genetic testing been available for people with epilepsy? You're on mute. Can someone you have to, oh, here we go. I think you should. There you are.
I'm unmuted now. Okay, I was getting blocked by the host. Thank you. Thanks, Mike and Irene. And thank you everyone for awesome questions. And I'll try to get through as many of these as I can. I don't think I'm going to get to quite everyone, so I'll save some of the more personalized case-by-case questions for the chat, because this is such an individualized process, right? There are already good examples in the chat of how family dynamics are playing in and family decisions are playing in. So I will get to those, I promise. But starting off with this first question about how long epilepsy genetic testing has been available, I don't know is the short answer there. There have been developments in genetic testing at a much higher rate over the last 20 years or so. We really started being able to do this on a clinical basis toward the turn of the century. That said, if I were to do, say, an epilepsy panel from my preferred lab 2 years ago, it might have contained only 150 genes. Whereas if I do that same panel today, it contains 320 genes. So that shows us how quickly the field is developing still today. We didn't know about half of those genes 2 years ago or have them associated with epilepsy yet. So I don't know if there is a short answer to when this started. It's an ongoing process and something that warrants looking back at every couple of years.
Thank you. Okay. Then the next question is that this person had asked their doctor about genetic testing. It was done, but not all of this was explained. Is it better and safer to get IVF, especially if epilepsy is in the family? So if there's a genetic component to the epilepsy.
Sure. I hear you when you say I didn't get all of this. That's going to be at the provider's decision, really, is how much information they're giving. And so what I want everyone to leave with today from the genetic testing discussion is that personalization piece. If you want more information, ask for it. If the doctor or the provider or the genetic counselor doesn't have that information, ask to talk to someone that does. It's really, really important that you play an active role in this conversation. And you're going to realize what's important to you at various times throughout your journey too. You might not realize what questions you have right in that moment. So I encourage you to keep this conversation ongoing. As far as the IVF piece, that is an option. I wouldn't say that it's better. I don't think that any one particular option is better. When you use that word safer, it makes me think, okay, if what's safe is what avoids epilepsy continuing on through your family. If that's what's most important to you, then IVF is a great option to look for the possibility of passing on the familial epilepsy variant, the one that we know is in your family. The same goes for a prenatal test. So conceiving the pregnancy without IVF, without technologies, because IVF is not accessible to everyone. It's expensive. Not every insurance covers it. There are a lot of decisions going into that as well. So some people may choose to try to get pregnant on their own and then go and get the pregnancy tested. That comes with its own risks and its own costs and its own considerations. For some people, they're okay with understanding that, okay, there's a 50% chance of passing this gene on or 25% chance of this other condition. So what I would encourage is a conversation with a genetics professional and explaining to them that that's what's important to you, is avoiding perpetuating that legacy.
Thank you. Is there a difference between a cheek swab, saliva, or blood sample? Is one better than the other?
There is not one that's better than the other. There are some situations where you can and can't get any of those. Honestly, often the deciding factor in my clinic is, has the person getting testing had anything to eat or drink or had anything in their mouth in the last 30 minutes. You can't do a cheek swab if that's the case. For some kiddos, especially our younger ones, maybe they're super drooly. Even then, maybe we can't fill a tube of saliva from them. How do we tell a 2-year-old that you have to create enough saliva to spit into a tube, right? Maybe some of us like to put things in our mouth, our fingernails, our hands, a binky. All of those things can throw off our results because a lot of things around us have different DNA than us, including binkies, as weird as that is to think about. And so in those instances, I'll say, just to be safe, just to make sure that this sample doesn't get contaminated, let's do blood. Blood is obviously harder to contaminate than anything in your mouth. Ew. But none is more accurate than the other. None is a stronger sample than another.
Should everyone with epilepsy have genetic testing?
You're asking a very biased person, right? The guidelines say that yes, every person that has epilepsy should and can get genetic testing to find out why that's happening at minimum. There are people that are stronger candidates for genetic testing. Maybe their treatment decisions rely heavily on finding a gene or ruling one out. But you'd be hard pressed to find someone with epilepsy that I'd say, no, you shouldn't have testing.
So this question is from a parent. They have a son who has epilepsy, and he had genetic testing done, so they know that he has a genetic mutation, or variant. But they've decided as parents not to be tested. They do have an older son. He's never shown signs of seizures, but the person is wondering, would they do genetic testing on him solely based on his brother? Or, would they, as the parents, have to be tested as well first to see if one of them has some genetic component?
I think this is going to depend on the provider, and on some other situational pieces. What I typically say is if there are no signs of epilepsy, especially in someone as old as 16, that probably no reason to test to see if that person is going to have seizures. Especially in a family where we know how to watch for seizures. At this point, we've already been through seizure care for someone else in the family, so we know what a seizure looks like and what precautions to take. Otherwise, if that 16-year-old decides someday that they want to have children and prepare for it mentally or medically, they might consider asking a preconceptual or prenatal genetic counselor to test them for the familial variant to see if it's something that they could pass on.
Thank you. Okay, so we have a number of questions left. I think we do have to wrap it up, but I will end with a question, and then Elena, if I understand correctly, you'll respond to the chat.
Yeah.
Okay, so that's
Absolutely.
terrific. And for people at the watch parties, just to reassure you, if you cannot see the chat at this time, we will be able to share those questions and answers with you after the conference is concluded.
Thanks, everyone.
Okay, so thanks so much. This was very interesting and much appreciated. And I know there are a number of questions and people really want more information, and that's what we are about. But we have to move on to the next session.
Thank you, Alana. Thank you, Irene, for fielding those questions, and we will get those answers to you in the chat and after the conference is over. Now we're going to move on to our self-management panel, and our first speaker is going to be Allison Kukla. She's from the Epilepsy Foundation, and I'll let her tell her story, and then we'll move on to the next couple panelists and open up for questions for all three after each of them get a chance to introduce themselves. Hi, Allison.
Hey, thanks so much, Mike. Did you want me to share my slides or?
Sure, we
Did
can.
you-
You can do
Okay.
that.
Awesome. Oh, I am actually not able to.
Okay.
The host.
So we can take care of that.
Okay. Thank you.
Why don't you go ahead and start introducing yourself, and then we'll put those
Yep.
slides right up.
Okay, awesome. So I am Allison Kukla, and good morning, everyone. As they shared, I work at the Epilepsy Foundation of America, but I'm joining in my personal capacity as a person with epilepsy, and I'm excited to share a bit about my journey living with epilepsy for almost 20 years. So if you go to the next slide, please. My seizure started my freshman year of college after participating in a 36-hour dance marathon university fundraising event. I came back to my dorm room, I fell asleep, and I woke up in the hospital. Little did I know I had a generalized tonic-clonic seizure that night, which woke up my roommate. She got the resident assistant, they called 911, and when I got back to the dorm the next day, I never brought it up. I was embarrassed, I was confused, and I just really hoped it would never happen again, which I know is the case with a lot of people with epilepsy. But unfortunately, the tonic-clonic seizure did happen again, and I continue to have seizures almost 20 years later. We're still working on that seizure control. So since that first seizure back in 2006 now, my seizures have changed over the years. Epilepsy is very much a journey. So after those two tonic-clonic seizures, I now have focal impaired awareness seizures that over the past couple years have only been nocturnal. And some years have varied. Some years I've only had 5 seizures, other years over 60 seizures, and some multiple in a day. So as you can tell, it's been a journey, but they all have one thing in common. They happen without warning, which is the scariest part for me. And, my husband and my friends, when they've experienced them, I've had them alone in an airport, alone on public transit, and in a room full of clinicians at an American Epilepsy Society conference, and no one realized I had one. I also had a seizure once at work, and I unknowingly hugged a coworker, which could be a little awkward, but luckily it was someone I knew and was friends with, and he was aware of my epilepsy, so it kind of helped not make it as awkward as it could have been. But I would say my scariest seizure was probably while driving back in 2010, and I haven't driven a car since. And you can see on the slide there just some other bullet points of my journey about all the medications I've tried and different things like that. If you can go to the next slide, please. And, as I really reflect on my journey with epilepsy, there's been many challenges, and I haven't always wanted to talk about my epilepsy like this, but I realize how important it is to share my journey since it can really help others. And as I mentioned, I had that car accident due to a seizure, and I haven't driven since. And I actually gave up my driver's license a few years ago. And thankfully, where I live in Chicago has amazing public transit. So I'm very privileged and grateful for that. It helps me get around. When I was first diagnosed, it took me years before I met another person around my age with epilepsy. Actually, the first person I met was 60 years old, and I thought I got an old person's disease, so it made it even more that I didn't want to talk about it or address that I had epilepsy. And the most recent change was my and my husband's multi-year unsuccessful family planning journey. I know we just kind of talked about it a little bit in the last session, but my epilepsy and some other health conditions just made it too complicated. But family looks different for everyone, and our dog loves being the center of attention. So, those are just some of the challenges, but I want to talk about hopefulness and, just some of the things about why I'm grateful for my epilepsy and the opportunities it's brought me. First, it may have taken 12 years, but I got connected to an epileptologist, which vastly improved my care. I've had such a meaningful career, both past and present, from working in President Obama's White House, as you can see on the slide there, to now at the Epilepsy Foundation, getting to offer bereavement services to individuals and just support to those in the community. So through all of this, I've been able to help others and connect with others about epilepsy and raise awareness in various ways that were not available to me when I was diagnosed. So, I can really only hope this helps break down the stigma around epilepsy a little bit, and I get to tell my story on amazing conferences like this. So if you can go to the next slide. As I shared, epilepsy is a journey, and I couldn't do it alone. On the slide here are just a few people in my support network, but I would say my number one is my husband, Preston, in those pictures there. Since my seizures are nocturnal, they wake him up. Nothing else wakes him up but my seizures, and he stays with me until they're over. And you can see the picture there. That's with my head wrapped in the EMU. That's from a 16-day stereo EEG stay. And he slept in the hospital on an uncomfortable window bed for 16 days. You can't find many people that would do that. And I also want to shout out my seizure action plan. everyone should have one, since I can share it with people so they know what to do if a seizure happens. That is one of the biggest supports that I have available as well. That's not a person. And then really regarding self-management, as I was reflecting on this, there's so many different things. So just trying to narrow it down. My husband and I track my seizures, and I had been tracking them for years prior so that we have that data for my healthcare team. I also use, one of those giant pillowcases to have my meds ready. And I also have my meds set to auto refill because it really helps me with my medication adherence, since that is, a really important part of your epilepsy journey and something that you can really help control to keep, taking your medications as prescribed. During our family planning journey, therapy was really critical for me. And it's also been helpful at other times during my journey. And I think it's so important to talk about that, the need for, taking care of your mental health as part of your epilepsy journey, because there are lots of ups and downs along the journey. So, I'm also comfortable disclosing my epilepsy and sharing, either depending where I was in my journey, my best friend's information or now my husband's information with people. So in case something happens, they know what to do. And lastly, memory is an issue that I've struggled with. And I know many people, we joke about our epilepsy memory brains and all of that. And there's a wonderful program called Hopscotch, which is a Managing Epilepsy Well program that focuses on memory and identifying strategies to help improve your memory. And so if you haven't heard about that, it is an amazing program. It's offered for free, and I highly would recommend checking that out. So if you go to the last slide, I just wanted to really, thank you for having me here today and allowing me to share my story and be on this panel. I'm always happy to connect with others. So I have my contact information there. So feel free to reach out. My husband and I often connect with others because there's not many, young adults and young adult resources out there. So, feel free to reach out anytime. And thank you for allowing me to be here today.
Thank you so much, Allison. And hang tight because we have two more panelists going to go, and then we will open up the for questions for all three panelists. So Matthew Windrum is next. He's an epilepsy advocate, and he will share his story. And thank you so much for being here, Matthew. We got to unmute. Oh.
All right, I'm unmuted. There we go. Thanks, Mike, and thanks for everyone in the coalition for having me here and letting me share my story a little bit. Particular thanks go to Janet and Irene from Epic Long Island, who I met earlier this year, and I know Janet extended me this invitation, so thank you, Janet, for that. I do appreciate it. I didn't bring any slides, but I do want to give you a little bit about my story and suggest some self-management tactics that worked for me anyway. I started having focal impaired awareness seizures when I was 29, probably the result of a head injury I had suffered the year before. My wife and I had just had our first baby, and I had just had a great new job when suddenly my mind was wandering off in what were to me at the time completely unexpected and really frightening ways. What these seizures consisted of me were a brief but acute sensation of dread, followed by around a minute or so of impaired awareness or confusion, in which I'd sort of forget the context I was in or what I was meant to be doing, and I'd gradually have to reorient myself. Eventually, I started having 1 to 3 of these per day on average for most of the next 9 years. I had some of the same experiences I know that many of us who are living with seizures had. At first, they were relatively infrequent, so I mistakenly thought I could somehow shrug them off or plow through. Then I was misdiagnosed by a primary care physician who thought I was having panic attacks and prescribed inappropriate medication with severe side effects. Months later, a neurologist correctly diagnosed my condition as adult onset focal impaired awareness seizures, but no combination of medicines worked to control them. It was only years later that I finally opted for the surgery, which was a right temporal lobectomy, removing most of my right temporal lobe and some surrounding tissues, that I ultimately achieved full seizure control after 12 years. In addition to the sensation of dread and confusion, there were, of course, the practical impacts of seizures. For instance, the inability to drive for years, high healthcare costs, difficulties advancing my career. I also distinctly remember the intense stress, anxiety, and fatigue that came with seizures for me. So I know everybody's situation is very different, and we all need to find our own self-management techniques. But I found a couple that really worked for me. First, it helped to ask for second opinions, even though I was sometimes too slow to do it. Maybe because I was lacking in some self-confidence in those days. I let my initial misdiagnosis stand for much too long before finding an epileptologist. And then I didn't speak to enough neurologists about surgical options while living probably longer than I had to with the seizures. So if you feel your treatment isn't working well for you or your family member or friend, I don't think it can hurt to ask for a second opinion. You might not hear anything different, but at least you'll have the peace of mind of knowing that you tried. Second, and Allison just said this, and I couldn't agree more, support network was invaluable. For me, it was really leaning on my family. My wife was incredible throughout, supportive and uplifting. My parents lived 10 minutes away, so they were always able to help do some of the driving and watch the kids sometimes. And I knew the kids would always be there for me. They went from newborns to 6 and 8 years old while I was having seizures. So they were too young to know it then, but their just being there was so, so important in such an anxious and stressful time. But I'm keenly aware that everyone's support network will be different. It could be family, but it could be good friends or religious or community organizations, including some of the great epilepsy organizations on this call. Bottom line is, I think everyone living with our condition should find a support group of some kind. And this audience is here, you know that already. But if you come across anyone affected by seizures who, for whatever reason, hasn't found their support network yet, please do whatever you can to help them build one. Third, it really helped me to have a couple people I could confide in at work. These, as I mentioned, my seizures were not entirely discernible to someone who didn't know me particularly well. So I didn't feel the need to share it across all 150 people at the job I was in. So between human resources and a couple of close friends, I thought it was really helpful so that I could confide in them when maybe I was having more seizures than usual on a given day, or when I perhaps missed an important detail in a team meeting because I was having a seizure in that moment. And finally, now, I wish I had known then what I can see in hindsight now is that I should have cut myself a little more slack. I wish I'd been able to more clearly see back then that no, maybe I wasn't going to be able to do everything exactly the same as I did in my first 29 years, but that I was still really accomplishing something great. I was holding down a good job and helping raise a young family while living with multiple seizures on most days for 9 years. I'm enormously proud of that now. And I think it would have relieved just a little bit of the stress and improved my self-confidence if I'd been able to see it clearly in those days. So I get to have this perspective in hindsight, but I think anyone who lives with seizures now, please try to give yourself some credit now and then. Being your best selves and always striving to do that while living with seizures is really a great achievement in itself. And don't ever believe for a second otherwise. So that's my piece. So thanks again for having me here, and I hope that was useful in some way.
Yes, thank you very much, Matthew, for sharing the story. And again, stay tuned. We'll open it up for questions in just one moment. Jamie Mulliger is on as our third panelist, and she's going to share her story. She is a epilepsy advocate as well, and volunteering and empowering people's independence as a co-facilitator for our PACES program. So welcome, Jamie, and you have the floor.
Thank you, Mike, and thanks for the invitation. I'm really excited to be able to share my story with everybody. So I guess I'll start. Like Mike said, I am a volunteer for EPI New York here in Rochester. And I volunteer mostly with co-facilitating the PACES support group. A little bit about myself. Um, I'm 43 years old, and I had my first seizure when I was 12 years old in the middle of middle school math class. Since then, I had been bullied. I was known as the freak in class. About a year later, I was diagnosed with epilepsy when I had more seizures. And since then, I had struggled for about 10 years on different medications, severe anxiety. I'd wake up every morning thinking, wondering, is this going to be the day where I have another seizure and I have to start over? I didn't finish high school. The anxiety was so bad. Very fortunate to have had a great care team. I can't stress enough. My neurologist, um, back when I was in my teens and early 20s, was fantastic. I finally was admitted to the hospital for the 24-hour EEG testing, where they were actually able to find a couple of different medications that worked for me. I went 5 years without having any seizures, and I was actually hopeful. I planned a wedding and I went to my neurologist and I said, I want to have a child. And he said I was on too many different medications that were unsafe. And we talked about it. And I'm so grateful and thankful to him for being so understanding. And I now have a 16-year-old son. When my son was 6 months old, I did have multiple tonic-clonic breakthrough seizures in one day. Since then, I have taken a lot better care of myself, and I have been seizure-free for over 15 years now. I felt like Allison, that being there for others in the epilepsy community, to share my story and be there for them, was just, it made me feel so good to be able to know, for other people to see that we can relate to them and that we've been there and we can provide tools and resources. That's why I joined the PACES group. I've been doing that for going on 2 years now, and it just feels wonderful to be there for others in this community. Um, you know, Throughout the years, though, I understand, the struggles with the anxiety, and, for a while there, I was pretty depressed. Um, you know, Throughout the years, though, I feel just very fortunate. It's very important, the support I had, mostly my family. I mean, I was diagnosed 20 years ago. I didn't even know EPI or the tools and resources existed during that time. So my mother was my main support. She was there for me throughout the years. Um, I've learned over the years it takes time to really understand your triggers. For me, my self management has been, being aware of my triggers and staying away from them, flashing lights, sleep deprivation. um, Everybody's different, and it's just getting that self-awareness to know yourself, your triggers, staying away from them, adjusting your routine in your daily life just to be able to remain seizure free. It does help. Routine, and there comes a point where you kind of reach a level of acceptance. I accept that I'm epileptic. I accept that my daily life might not be like others because I have to be more aware and more careful. um, but I made it, and I feel very fortunate, and that's why I do what I do, and I'm there for others. Even though I've been seizure free for so many years, some people don't understand. It still affects you. Every day I wake up in the morning and I worry, I have anxiety. It might not be as much, it might lessen throughout the years, but I still wake up asking myself, okay, is this going to be the day? Is this going to be the day where I have a breakthrough seizure and I have to start over? Um, but like I said, adjusting my routine. My seizures usually happen within 2 hours after I'd wake up in the morning. So it's still to this day, I make sure I'm awake early enough and I don't drive until after 2 hours because that's what I have to do. But, all these, the awareness has really helped me remain seizure free. I'm only on one medication to this day. And that's because I stay away from my triggers. I know I've been self-aware, and unfortunately it takes time to really, understand your body, be able to listen to your body and be aware of those triggers to stay away from them. So if I had, one piece of advice to everybody, pay attention to yourself, pay attention to your body. It talks to you. Be more aware, write things down, use the tools and resources, contact your local foundations, and just be there for each other.
Thank you so much, Jamie. Wow, great panelists here. So we're going to open up for some questions for both Allison and Matthew and Jamie, and we're going to welcome back Irene to be able to answer to ask some of those questions out of our chat.
To echo Mike, my goodness, wow. Thank you to each of you for sharing your personal journeys. It can be difficult, but what you are giving to each of the attendees today is so powerful. And I'm sure each of your stories have resonated with the audience. So, and oftentimes people living with epilepsy can feel isolated, can feel alone, or think that no one else understands. In part because of some of the experiences that they go through, but also too, just, we're human, and we have these doubts, self-doubts. But, there are a number of questions in the chat, and so I'd like to just jump into those, and you can field them as you would like. I'll let you choose. Someone commented, I think they were referring to hopscotch, but also PACEs. Jamie, you had mentioned PACEs. So we can give information at a later time about those two programs, but I would just encourage anyone in the audience, if you're looking for support, looking for different types of self-management programs, the agencies who have put together this conference are a great resource, and we can direct you accordingly. So someone had asked about Walk Score. Is there a better resource than walkscore.com to find cities to relocate to for work if necessary? I only accept roles in Chicago or New York City now because I'm not even judged for being on a bus or saying I do not have a car. So a big issue, right? Driving and not being able to get around. I can say safely for Long Island, it's difficult if you don't have a car.
I was lucky enough to be going from the suburbs of New York into New York City every day, so Metro North was as important as it gets in that period of my life.
And I would say, like, I grew up in Northeast Ohio, but otherwise I've mostly lived in big cities. But definitely when driving was taken off the table, it's challenging. So yeah, my husband jokes that I'm the passenger princess since he has to drive everywhere. But definitely, even if you're not in a big city, I know you're asking about Walk Score, there are other resources, because when I did live in a smaller town in Virginia for a couple years, they had a small like rail system, and it got me to the health department where I worked at, or I could bike or walk or things like that. So and I know there are rideshare programs that the National Epilepsy Foundation offers, Uber vouchers, and some of the local offices offer too. So there's different resources out there to assist with funding to help folks get around as well.
Jamie, do you want to add anything to that, or?
Sure. I mean, back when my seizures were active, it was very difficult. We didn't have Uber or Lyft. But for me, it was a struggle. Like I said, I was unable to finish high school due to anxiety. I did try and go to college, but I did end up having a seizure and crashing my car, and therefore I could not, find any transportation to and from. If I did need transportation, every now and then I did have a good support system. But now, like Allison said, there's Uber, Lyft, vouchers. Connect with your foundation, and I relied a lot on my family and friends. But it was definitely a struggle and I completely understand it's not easy, but just reach out to those people that love you and care about you, and put a plan in place. I'm a big, for planning, have a plan in place ahead of time so you're not worried about it. It reduces your anxiety knowing that you have a solution to get where you need to go.
Thank you. How do you disclose to people you work with about your health condition?
Yeah, so that is definitely, I'm happy to start. I'm sure we all have different answers about how we address that. It definitely depends on the workplace you're in and your comfort level. Disclosure is such a personal issue. I know in the various workplaces I've had, more likely than not, I've had the privilege of having a positive experience when I've disclosed. And for me, it's been really finding those people that you trust to disclose, because for me, I know it makes me safer having at least like one person or two people at work know something has happened, or like know what to do if something happens. So I've used it as an opportunity to educate them on seizure first aid, share my seizure action plan, share an emergency contact. Because when I was working at the White House, I had a focal seizure. Didn't know I had one. This was when they were happening during the day. And then the next day at work, sat down with my boss and she's like, hey, so this happened, like, how would you like to address it? And I really appreciated her being so open about how do I want to address it. And so we worked together to draft an email for the staff to be like, hey, so this is what happened. So and so noticed it. This is what you should do. If you have any questions, like, please talk to Allison. And I used it as a training opportunity for the staff. But I know not every place is like that. But like I said, I've used it as a way because I know it makes me safer. And just, you don't have to tell everyone. If you have one or two like really close friends at work or trusted colleagues, and I see Matthew nodding along, just having those people that can like get in touch with a loved one if something happens or anything like that. And I know Matthew touched upon this as well.
Yeah, and just to add to that, I've exactly had the good fortune to be in those workplaces. I didn't want to tell, dozens of people, but just having those few people offered some solace and some comfort when I was having those active seizures. And also, to be honest, like what I said, some memory support. If every now and then there was something that had slipped through the cracks for me, they could often fill me in afterwards.
For me, I'm fortunate enough to work in, environment where they're very understanding. I know it's not easy for some people, but I think, like Allison said, it really does depend on your comfort level. Sometimes we forget to advocate for ourselves. So to kind of go off of, what Matt said, and like Allison, I do have some memory problems from having so many seizures and medication. And my boss, he was at one point he cracked a joke about, oh, I can't believe you couldn't remember that. We just talked about it yesterday. That was like my reality check for me, like, hey, you need to speak up for yourself. So I had a conversation with him and I said, listen, I have memory problems for a reason. I'd appreciate it. It does make me feel very bad when you make jokes about my memory. And this is why. And from that moment on, this was 3 years ago, from that moment on, he's been supportive and he's been understanding. And he actually reminds me about certain things, puts things on my calendar. So I think my point is advocate for yourself, especially if you feel comfortable and you know the person, because sometimes we do forget to speak up for ourselves. There's that one conversation and it stopped and it made my life at work so much more smooth, so much easier. And like I said, I'm very fortunate to at least work in an environment where people are so understanding.
You're hesitant to speak up at first, but then that really was so powerful and a game
Yeah, I
changer.
think at one point it kind of slipped my mind. I was like, it kind of became the norm for me. So I kind of forgot to speak up for myself until that happened. And I didn't feel very good about it. So I felt like I had to speak up about it. And I didn't blame him for it because he didn't understand. He didn't know. And they're not going to know unless you explain it to them.
Okay, there are a number of thank yous and, that this is so powerful and really heartfelt, and everyone is appreciative of you sharing. There is a question specifically for you, Jamie. Let's see, if you had this morning seizures, what was it like with your son? weren't you petrified? How were the first few years when babies wake up and don't sleep all night?
I guess I was very fortunate. I was 5 years seizure free before I had my breakthrough seizures when my son was 6 months old. And I had a lot of support. I had it planned. Like I said, it made me feel less anxiety. I had a plan. My mother-in-law and my mother, they took turns staying with us at the house and staying up with my son throughout the night so that I could get my sleep. So for me, it was all about just pre-planning, knowing when the help was going to be there and available, sleeping with whenever my son slept, I slept, and I was very fortunate. He was a baby that ended up he started sleeping 6 hours throughout the night at like two months old. It was amazing. So I was very fortunate. Everything just really did work out for me. I made sure that, I was always somewhere safe in the morning, that he was safe. It was, pretty much just having a plan in place and implementing it when the time came is what worked for me.
Thank you. This is a very timely question. The attendee is asking about how to manage the holidays, especially when you want to participate in events that may have triggers such as flashing lights.
Yeah, I think, this is very timely. Stress and lack of sleep are triggers for me. So, around the holidays, there's, a lot more commitments and things like that. So just echoing what, Jamie has beautifully said a few times, making sure you have a plan in place. And, if you have to say no to things, like, that's always hard and doesn't always feel great, but it's okay. And like, if they're your people, they understand why you might have to leave early or might not be able to attend something because, you need to get your sleep. And then just managing stress, like having mechanisms in place to do that. I know for me, it's exercise, and just relaxing on the couch with the dog and whatnot after like a busy day, and things like that to, just try to manage those triggers that, come in play. Because I know for me, we've learned a new trigger when we are family planning, hormones. So my menstrual cycle, catamenial epilepsy as it's called. So I know 2 times a month can be a little more touch and go with possible seizures. So I know to be a little more careful around those times. So definitely having a plan in place and, just knowing your people that they are there for you and there to support you, if you need to like step away or something like that. But yeah, I think planning is definitely, the biggest factor.
Well, we do have to close this session. There's so many questions, and I really we are so appreciative of your time and sharing your personal stories. There are a number of questions in the chat. I don't know if you would be able to respond to them while the next presentation is about to start. If you could, that would be terrific. And thank you. And also too, just for the audience, again, the watch parties, you're not able to see the chats and questions, but there are some resources that have been put in there as well, specifically about cities, where to live when you don't have a car. So
Thank you, Irene. Thank you to the panelists, Allison and Matthew and Jamie, for sharing your story. And self-management is so incredibly important when having epilepsy. And we really appreciate your stories and the advice that you have for us today. So moving on to our keynote speaker, Gianna, we're going to hear from Gianna's story, and then we're going to have some time for people to also ask her questions once the message is delivered.
Hi, my name is Gianna Spirio, and I would like to start off by saying thank you so much for this amazing opportunity to share my story with you all. I hope that in sharing my personal experience with epilepsy, I hope you take away feelings of hope, encouragement, and positivity. I was diagnosed with epilepsy at 2 years old with partial complex seizures. I can't imagine all of the emotions that my parents had during that time or what was going through their head. but I thank God every day that I was blessed with parents who were built to take on the responsibilities of having a child with a disability and excelled at it. And I am forever grateful for my support system. I may have not loved the tough love approach at the time. For instance, if I called my parents from school telling them I was experiencing an aura or anxiety that an aura was going to happen, I was told to stick it out. And then when I would come home, I was asked if I had a seizure. And when I said no, I was told, "That's great. What did you learn today?" I didn't love it at the time, but I am very grateful for it now. When I was growing up, I had an individual education plan throughout my early childhood education, and school was never something that I excelled at. Even as an epileptic, my parents signed me up for every sport and every activity that you could think of. I was always encouraged to be the best person I could be, no matter what hand was dealt to me. For 21 years, I was having seizures weekly and clusters whenever my equilibrium was even remotely off. After years of trial and error with medications, we soon learned that I had intractable epilepsy, which is also known as drug-resistant epilepsy. As hard as that was to hear, I was still encouraged to keep moving, and what doesn't kill me makes me stronger. But I'll tell you, hearing all those positive words started to get really old as I got older and there was not yet a light at the end of my tunnel. Even though my seizures were not controlled, I still tried to keep the positive mindset that was drilled into me from such a young age. So I continued sports and typical activities because I was just forever longing for that normal life that I never thought I'd have. In high school, my friends and classmates were getting their driver's license, going to pool parties, going to the mall with their friends without their parents. And I was left feeling like the child that was never going to grow up because my parents were constantly there driving me and keeping an eye on me just in case I were to have a seizure. I think that the hardest part about having epilepsy is that it is a disability that is not visible to the naked eye, and that makes life a bit more complicated because most people do not understand what they can't see. And throughout my life, that led to horrific bullying and discrimination on multiple different occasions. Most of the time, when I aspired to do or be something, I was told that I couldn't because of my disability, and my answer was always, "Yeah, watch me." The bullying and discrimination by both children and adults was mind-boggling. But the lack of independence and the paralyzing fear of having a seizure at any time, anywhere, was what really put me in a very deep depression for years and years. And just what I needed, more medication and therapy. But I was still willing to do whatever it took to be seizure-free. I was fortunate enough to qualify for brain surgery when I was 13. Unfortunately, due to the epilepsy starting on my speech and motor skills, there was nothing they could do at the time. But as I grew older, technology was rapidly advancing, and I tried everything from brain mapping to the RNS system to eventually a successful laser ablation done mainly by robot. I have a passion for helping others in the way that I was never helped. Everything I do, I want it to benefit somebody else and make their life better and easier, whether it's volunteering with the Guide Dog Foundation or being part of the Domestic Peace Corps and worked with Habitat for Humanity and built houses. I still wasn't healthy, but I was very determined to help other people because that brought me purpose and happiness to my life. I thought that I thought that I would have to live with my parents or a caregiver of some sorts my entire life. And I believed I was never going to drive or be independent. I never thought I would make it through college, but because of my resilience, faith, and family, I stand before you 3 years seizure-free, with a driver's license, a car, living on my own, pursuing a career I'm extremely passionate about, and finishing up my master's program to be an early childhood special education teacher. I believe that all things are possible with a strong heart and mind. If you're ever feeling like it's time to throw in the towel, like I did almost every day for years on end, just know that there could be a light at the end of the tunnel, and it is the most amazing feeling in the world. I wouldn't be where I am today without my amazing, dedicated support system of my family, friends, and doctors. Epilepsy is a scary, cruel, and isolating disability, but I believe that if you are grateful for the little things that you can do, then there is no limit to what you can accomplish. Thank you.
Again, wow. Thank you very much, Gianna, for sharing that story. And right now, we can take some questions through the chat for Gianna. And again, thank you so much, Gianna, for sharing your story.
Good morning, Gianna. I think you're on mute. Everyone goes through this little trial. I can't begin to tell you how many people are commenting on what you just shared. You know, so many people saying, amazing, Gianna, thank you. Great advice. Congratulations. You know, just everyone is so happy for you. You know, you've had a difficult journey. And certainly it can be appreciated that you were not sugarcoating it. You struggled and you have come out on the other side of this amazingly, you know, and you're accomplishing so much. You have commented that you are an open book.
Yes.
And that you are willing to field any questions. What I'm seeing more than anything is just people being really inspired by you and commenting on that and sending you lots of love. So I'm just going to encourage, if anyone has questions of Gianna, to put them in the chat at this point. And, you know, if maybe, you know, you had talked a bit about, you know, feeling bullied. You were, you know, targeted by not only your peers, but also adults.
Yes.
Could you talk about that a little bit more, and then how you handled that? Because that's really quite a struggle to be faced with.
Yeah, you know, it was, especially in high school with teachers and coaches. For instance, I made nationals with track in high school, and I was supposed to go to North Carolina, but they told me I can't go because, God forbid, I had a seizure and I had to drop out last second. So that was just you know, another opportunity I missed out on, and definitely an occasion where my parents emailed Janet Romeo to handle it. But that was it was crazy. Coaches, teachers, you know, they couldn't understand because I looked like every other kid. You know, I didn't have a limp or a stutter, so, you know, I didn't have anything wrong with me. And no one no one understood. So it was kind of sad. But, you know, even throughout, you know, college, on the sports teams, if I feel that if you are really good at something, but you also have, you know, you have a disability or an illness, something to handle, people don't understand that you can still be good at things. So it was very hard playing soccer in college. But I got through it, and now, you know, I just want to advocate for, you know, those who may be going through the same things that I did. It wasn't easy at the time. So sorry, I'm just reading some of I'm seeing if I get any questions.
Well, there are a few.
Okay.
And yeah, I mean, you are inspiring because you have had to fight through a lot. And, you know, so everyone is so positive and encouraging in the chat. So one of the questions is, can you elaborate on the ablation?
Sure. So I had the RNS, responsive neurostimulation device in my head, and that was able to not stop my seizures, unfortunately, like it was intended to, but it was able to collect a lot of data that helped out the doctors with what to ablate in my head. So I had my RNS removed, and then about a month later, I had the laser ablation, and I had, you know, the SEEG done, a lot of so sorry, a lot of like research went into it throughout the years. Because as I aged, all of these surgeries were just coming out, and I just happened to be eligible for them. But all of the surgeries that I did do were able to gather a boatload of information for the ablation to be successful.
Do you participate in any epilepsy support groups?
I don't. I wish I did more. When I was suffering from seizures, I went to a couple meetings over at the Epilepsy Foundation in Long Island in Hempstead. But other than that, not too much. I mean, I wish I had more of a presence in epilepsy support groups, you know, talking to other people about it. But at the time, I don't really have much of a part in support groups.
Well, and I can say from, we had an education program, and you were an attendee, but then by sharing during the question and answer period, so many people turned to you in that particular program, and they were just, again, so inspired by what you had to share. And it was almost as if an informal support group was set up in that moment.
Yeah, really.
What would you say to a newly diagnosed 5-year-old with complex seizures to encourage them?
Oh,
Or any kind of seizures, I would suppose.
yeah. Man, you know what? I would probably tell them, do everything that you can. Don't stress yourself out though. Stress management is a huge part of being seizure free, but you know, who knows how to manage stress? Definitely not a 5-year-old. I, you know what? Keep going, do your thing. You know, I haven't really thought about it. I have a few students who have seizure disorders. I speak with their parents, just about how, you know, keep them in everyday, their everyday activities. And I know a lot of parents can be very coddling when they have a child with a disorder, and you can't be. I learned that my parents coddled me, but also I had a good amount of tough love. But I don't necessarily know what I would say to a 5-year-old to get my point across.
Someone commented that you are tough as nails, and they're so happy that you're achieving your goals. You are
Oh, thank you.
inspiring. And another question, I believe this is the last one. If you don't drink and want to be at an event with people who are drinking, what do you do to put them at ease, especially in college or after a work party, something like that?
You order a seltzer with lime, because you can say it's whatever you want it to be. It could be a tequila soda, it could be a vodka soda, it could be whatever you want, but seltzer and lime. And you just fit in. If you want to avoid questions, that's the go-to drink. Or get something with a garnish on the rim, and you don't have to explain yourself to anybody.
A little umbrella, right?
Yes.
Yeah, very practical advice. Yeah, something that, you know, people won't be able to tell what it is. And
Yeah.
you don't have to get into a big explanation, and no one has to feel uncomfortable.
Seizures aren't my go-to party talk, you know, conversation, so I'd rather just avoid the whole thing.
Well, the audience member appreciated your suggestion. They said it was a great idea.
Oh, good.
Thank you so much, Gianna.
Thank you, guys.
Yes, thanks, Gianna, so much. I appreciate that. It was a really great message, and I'm glad that we were able to, you were able to answer some questions from the attendees. So what we're gonna do now is we're gonna take a short break. We're going to get up and stretch and get yourself something to drink. Maybe not what Gianna was just talking about, but something to cleanse your palate. So we'll reconvene at 11:30, and we're going to have Dr. Ning talk about treatments in epilepsy. So hang tight, and we'll see you in about 14 minutes. Welcome back, everyone, from our little break. I am excited for our next presentation. It's Dr. Elizabeth Ning. She's going to be talking about current treatment options in epilepsy, and I hope you enjoy.
Hi, my name is Dr. Elizabeth Ng. I am a pediatric neurologist with the Connecticut Children's Medical Center. And welcome to the Epilepsy Coalition 2024 Annual Epilepsy Conference. And I will be talking about the current management in epilepsy. So the main objectives of my talk is to understand the two major principles of action by which anti-seizure medications help inhibit seizure activity, know which ASMs can be used for focal epilepsy versus generalized epilepsy, and how do we determine what is the best seizure medication for our patients out of a list of potential seizure medications. So in order to decide which is the best ASM to choose, you have to understand the basic principles of seizure propagation. So there's either an increased neuronal excitation or a decreased neuronal inhibition. So if excitement is greater than inhibition, as you see in this cartoon, you have a seizure propagation. So there's a neurotransmitter called glutamate that's involved with increased excitation. So if there is increased glutamate release or too much glutamate, a seizure will be generated. And as opposed to, there's a neurotransmitter called GABA, which is involved with inhibition. So if there's a decreased GABA or too little GABA, a seizure will be generated. So anti-seizure medications act by one of two mechanisms in order to stop seizures, either enhancing GABA inhibition or reducing the excitatory glutamate transmission. So you see in this cartoon, these are the glutamate receptors that mediate excitatory synaptic transmission of glutamate, namely the voltage-gated sodium receptors, the voltage-gated calcium receptors, the potassium receptors, and also the synaptic vesicle glycoprotein 2A, which is involved that regulates the release and reuptake of the neurotransmitter glutamate. So you see here, these are the anti-seizure medications that work at the voltage-gated sodium receptor to decrease the transmission of glutamate, therefore decrease excitation, and to stop the seizure. These are the medications here listed that works at the voltage-gated calcium receptor, which works to decrease glutamate transmission and therefore decrease excitation and seizures. And here, the ezogabine works at the potassium receptor, but is now currently out of market. And these medications here work at the synaptic vesicle glycoprotein 2A, or SV2A, to decrease the release and reuptake of the neurotransmitter glutamate. So these are the presynaptic receptors. Now here are the postsynaptic receptors for the glutamate, glutamatergic synapse, namely NMDA, AMPA, and the voltage-gated calcium T receptors. So here's the anti-seizure medications that work at the NMDA receptors to decrease glutamate transmission. These are the medications that work at the AMPA receptors, and these are the medications that work at the voltage-gated T calcium receptors to decrease glutamate transmission to stop seizures. So at the GABAergic synapse or inhibitory, we have receptors, namely GABA T and GAT1, that's involved with GABA transmission or inhibition. And these are the medications here that work at the GABA T to increase GABA and therefore increase inhibition to stop seizures. And these are the medications that work at GAT1 to increase GABA transmission and therefore increase inhibition and stop seizures. At the postsynaptic membrane, we have the GABA A, which is involved with increasing GABA transmission. And these medications here, the benzodiazepine, phenobarbital, the pyramate, cenobamate, they work at the GABA A receptor to increase GABA transmission and therefore increase inhibition and stop seizures. So if monotherapy fails, you want to select a second anti-seizure medication with a different mechanism of action, and this is called rational polypharmacy. So these are the classic anti-seizure medications that were developed in the 1850s and the 1960s, like bromides, phenytonin, ethosuximide, and phenobarbital. These are the anti-seizure medications that was developed in the 1970s, like clonazepam and valproic. These are the newer generation ASMs that was developed in the 1990s and the early 2000s, like felbamate, topiramate, ceniramide, lacosamide, rufinamide. And you see here in clobazam, and in 2016 is briracetam was developed, and 2018 CBD, and the newer ones is that was developed in the 2020, like cenobamate and fenfluramine, and you see ganalosolone developed in 2022. So with all these seizure medications, how do we know which seizure medication works best for our patients? So you want to take certain things in consideration, mainly the seizure type, the epilepsy syndrome, the side effect profile, the biological sex of the patient and the reproductive capabilities, also the comorbidities and the drug-to-drug interactions. So this is the classification of epilepsy by the ILAE. So they divided based on seizure types, focal, generalized, and unknown. The epilepsy types, focal, generalized, combined generalized, and focal, unknown, and the epilepsy syndromes. So there are comorbidities seen in different epilepsy types and epilepsy syndromes, and the etiology can be either structural, genetic, infectious, metabolic, immune, or unknown. So the ILAE updated the classification of seizure types in 2017 into focal onset, generalized onset, and unknown onset. So for focal onset, it can be either aware or impaired awareness, motor onset or non-motor onset, focal to bilateral tonic-clonic. For generalized onset, it can be motor, tonic-clonic, other motor, or non-motor, namely absence. And the unknown onset can be motor, which is tonic-clonic, other motor, non-motor, or unclassified. So focal onset seizures can be either focal aware, focal with impaired awareness, focal seizures evolving to generalized seizures, and the generalized seizures can be generalized tonic-clonic seizures, absence seizures, tonic seizures, atonic, or clonic seizures. So generalized seizures were previously called primary generalized, and this involves networks on both sides of the brain at the onset. And they're all presumed to affect a person's awareness or consciousness in some way. So no special terms are needed to describe awareness in generalized seizures, as opposed to focal seizures, which are previously called partial seizures. They start in the area or network of cells in one side of the brain. And describing focal seizures, we describe awareness. So either focal aware, if the awareness remains intact, even if the person is unable to talk or respond during a seizure, the seizure would be called a focal aware seizure. And this replaces the term simple partial. And focal impaired awareness is if the awareness is impaired or affected at any time during a seizure. So even if a person has a vague idea of what happened, the seizure will be called focal impaired awareness. So this replaces the term complex partial seizure. Unknown onset is if the onset of a seizure is not known. However, later on, the seizure type can be changed if the beginning of a person's seizures becomes clear. So focal to bilateral seizure was previously called secondary generalized seizure. So that's a seizure that starts in one side of the brain and spreads to both sides. And now the term generalized refers only to the start of a seizure. So now that we know the classifications, how do we choose the right drugs? So here we see we can decide on the best ASM based on the seizure type, either focal onset or generalized onset. So focal onset with preserved or impaired awareness, or focal to bilateral. And so these are the medications of choice for the focal onset seizures, like oscarbazepine, gabapentin. And for the generalized onset, we have tonic-clonic, tonic, myoclonic, atonic, and opsons. So here you see the medications of choice like fenfluramine, clobazam, rufinamide, felbamate, CBD that can be used for generalized onset. And for opsons, we could use ethosuximide. And over here, these are anti-seizure medications that are broad spectrum because they can treat both focal onset and generalized onset. And that's namely Reproic, lamotrigine, topiramate, levetiracetam. And so medications that are FDA approved for all generalized epilepsies are Reproic acid, lamotrigine, levetiracetam, topiramate, perampanel, and locosamide. But ethosuximide is only used for absence epilepsy. So for childhood and juvenile absence epilepsy, ethosuximide and Reproic are the only ones approved by the FDA as first-line therapy for patients who only have absence. Lamotrigine, levetiracetam, and topiramate are approved as adjunctive treatments by FDA for patients who have generalized tonic-clonic and not just absence. So for juvenile myoclonic epilepsy and generalized tonic-clonic seizures, the FDA approved drugs are Reproic, lamotrigine, levetiracetam, and topiramate. So even though cinesimide is not FDA approved for primary generalized epilepsy, it's effective in treating generalized seizures. So medications that are appropriate to localization-related epilepsy are really any of the FDA-approved anti-seizure medications except for ethosuximide. So the FDA approved perampanel for primary generalized tonic-clonic seizures. As you can see here, the median seizure reduction was 76% for perampanel compared to 38% for the placebo. So the anti-seizure medications to be used for epileptic encephalopathies are clobazam, felbamate, rufinamide, CBD, fenfluramine, and serpental. So it's very, very important to consider the biological sex of the patients because there are certain anti-seizure medications that can cause fetal malformation, like Reproic acid and phenobarbital. So you should really consider ideally not giving these medications to women in the reproductive age. So it's important to follow the pregnancy registry for updated results on major birth defects. So here are the listing of the pregnancy registry lists. There's a North American pregnancy registry at Mass General, United Kingdom and Ireland pregnancy registry, the European pregnancy registry called EURAP, and the Australian registry. So in considering a single ASM for a patient, it's very important to consider the comorbidities. So you can treat both the epilepsy and the comorbid condition, like migraines, mood disorder, increased weight, or neuropathy. So for migraines, we have Reproic, topiramate, and gabapentin that treats migraines. So if a patient has migraines and seizures, this will be ideal this will be a consideration because it's also anti-seizure medications. So if the patient's struggling with obesity, you may want to consider topiramate, cinesimide, and felbamate because they are both anti-seizure medications and medications to treat obesity. And for some of the affective disorders, Reproic and lamotrigine are good choices, and they're in addition also good anti-seizure medications. So it's important to also consider the drug interactions with other medications. So some of the older ASM can reduce the efficacy of the OCPs, like phenytonin and phenobarbital. And some of the newer ASMs can also reduce the OCP levels, like felbamate, oscarbazepine, rufinamide, and topiramate at higher therapeutic doses. And the oral contraceptives can also reduce some of the plasma levels of some of the ASMs, namely lamotrigine. So the oral contraceptive can reduce lamotrigine plasma levels. So if there is an individual that's on an OCP and also taking lamotrigine, it's important to adjust the dose of lamotrigine so they would not have breakthrough seizures. And there are newer pharmacological therapies available for children, namely cenobamate, fenfluramine, ganaxolone, and some of the rescue intranasal diazepam and midazolam. So cenobamate is currently approved, FDA approved for treatment of focal onset seizures in adults. It's not yet approved in children, but there's currently ongoing clinical trials to assess the potential side effects of cenobamate in children. They block the sodium receptors and they modulate the GABA-A receptors. And studies have shown a significant reduction in seizures in children. There's been a greater than 50% reduction in seizures in 38 to 62% of the patients. And the most common side effects found was somnolence, fatigue, and psychiatric. Fenfluramine is FDA approved for Dravet syndrome and Lennox-Gastaut syndrome for individuals over the age of 2. And may also be effective in treating the CDKL5 deficiency disorder with a medium 9% reduction in seizure frequency, and has also been used as an adjunctive therapy for sunflower syndrome. Brivaracetam has been approved by the FDA in 2016 for focal and generalized epilepsy. And it works on, it's highly selected, has a highly selective affinity for the synaptic vesicle glycoprotein 2A, SV2A that we saw earlier, which regulates the release and reuptake of the neurotransmitter glutamate, which allows a decrease in the neuronal excitability in the brain. And the main adverse effects of this medication is mainly drowsiness and irritability. So ganaloxolone is specifically used for patients with CDKL5 deficiency disorder, which is a rare neurodevelopmental and epileptic encephalopathy that's characterized by infantile onset epilepsy and severe developmental delays. And most individuals with CDD develop refractory epilepsy with multiple seizure types. And it's also effective in treating PCDH19 clustering epilepsy, which is caused by a mutation of the PCDH19 gene located on the X chromosome. And this is characterized by occurrence of treatment-resistant epileptic seizures, intellectual disability, autism, and behavior disorder. And about half of those taking this medication report a decrease in the seizure frequency of more than 50% within 28 days. And the main side effects that they've seen were drowsiness, mental confusion, excitement, and GI stress. And we also have 2 abortive intranasal seizure medications, namely midazolam nasal spray, which is brand name Nasolam, and diazepam nasal spray with the brand name Bertoco, which is the same medication used in a rectal form called Diastat. So when is a patient considered drug resistant? They're considered drug resistant if they fail at least 2 seizure medications to control the seizures at an appropriately chosen ASM and at the appropriate dose, or if they failed a rational polypharmacy, or the failure is not due to non-compliance. So you can see here, 63% of patients respond to ASM and remain seizure-free versus 36% are refractory. So what are the patient's chances of responding to 3 or more ASM? So the patient's chances of responding to the first ASM is 50%. To the second ASM is 11%, but it becomes significantly less with the third ASM. So about a total of 66% will respond to ASM and 33% are intractable. So what do we have to offer to the 33% of patients that are intractable? So there are other treatment options, including neurostimulation, surgical resection, and diet therapy. So you can see here, for the resective surgery, we have temporal lobectomy. For the open loop stimulation, we have deep brain stimulation of the thalamus, vagus nerve stimulation. For the closed loop stimulation, we have responsive neurostimulation. And for the targeted ablation, we have LIT, or laser interstitial dermal therapy. So neurostimulation is the application of electricity to the central nervous system to reduce the seizure frequency and severity. It's either open loop or closed loop. So open loop is when you deliver a continuous stimulation in a predefined pattern without feedback. And that's the vagus, namely vagus nerve stimulator and the deep brain stimulator. The closed loop is when the stimulation is delivered only when the device detects a certain condition, and that's the responsive neurostimulation. So these are the available neurostimulation for epilepsy, namely VNS, RNS, Sante, which is also known as deep brain stimulation. So vagus nerve stimulator was FDA approved for intractable focal epilepsy in 1997. It's safe and effective, and it has also been well proven to help other different seizure types. The first human implant was in 1990 and it's approved for individuals 4 years and older. And you can see a cuff is threaded around the left vagus nerve and then connected to the VNS generator, superficial to the pectoralis muscle. And then you have a magnet that swipes over the generator to activate the stimulation. So the vagus nerve stimulator is indicated for individuals with seizure onset zone that is generalized, or if they have greater than 2 epileptogenic foci. So studies have shown that a median of 51% of patients achieve a greater than 50% reduction in seizure frequency. In addition, the efficacy increases with time, and the quality of life improvement was 30 to 60%. And the common side effects are voice changes or hoarseness that's seen in 55%, coughing in 15%, dysphagia in 38%, neck pain in 15%. And seizures were reduced by more than 50% in approximately half the patients, and is effective in drug-resistant epilepsy and Lennox-Gastaut. So responsive neurostimulation, RNS, the stimulator is placed in the skull, and electrodes are implanted near the epileptic focus using depth or subdural strips. The seizure pattern detector, IEEG, which is within the device, are programmed to trigger direct cortical stimulation when a seizure is detected. So this is a closed loop system. The RNS was approved by the FDA in 2013 for the treatment of focal drug-resistant epilepsy in adults. It is not presently FDA approved in children because of limited experience. However, some of the pediatric epilepsy centers are implanting RNS off-label, and those centers are familiar with the RNS use in adults, and it's designed to abort seizure activity. So the indication for RNS is in individuals with focal epilepsy, refractory to greater than 2 ASM, and they have greater than or equal to 3 seizures per month for greater than or equal to 3 months. And the seizure onset zone is in the Allegrein cortex or the language center. And also there's not more than 2 epileptogenic foci. So you can see here, there's a spontaneous seizure right here. Then the electrostimulation aborts that seizure, and that's what occurs with the RNS. And studies have shown that there's a 53% median seizure reduction in 2 years after implantation, but a 66% reduction by 6 years. So the responder rate improves over time. And in the pediatric patients, studies have shown a greater than 80% reduction in seizure frequency. And RNS is generally well tolerated. You can see risk of infection in about 4%, intracranial hemorrhage about 5%, and lead damage in about 3%. So we also have deep brain stimulation, DBS, and this was FDA approved for use in intractable epilepsy in patients 18 years of age and older in 2018. So you have a permanent generator implanted superficial to the pectoralis muscle. Then the electrodes are placed in the bilateral anterior nucleus of the thalamus. So the anterior nucleus of the thalamus is seen as a relay station that amplifies and synchronizes discharges from the hippocampus and the posterior thalamus. So by stimulating the anterior nucleus of the thalamus, you can abort the seizures. And 69% there's a 69% median seizure frequency reduction after 5 years in adults. And is FDA approved to treat, again, intractable epilepsy in adults that has greater than or equal to 6 seizures per month, or is refractory to greater than or equal to 2 ASM. The data is lacking, however, in the pediatrics, but several case reports show that it's promising because of its tolerability and its efficacy. And there's a median percent seizure reduction from baseline at 1 year was 41%, and 69% at 5 years. So deep brain, so case studies have shown that in DBS in children, there's a greater than 50% seizure reduction. And the Sante trial found that the common adverse effects were implant site pain and paresthesias, infection and lead misplacement, depression, and memory impairment. So here's a summary of the FDA-approved invasive stimulation approaches. So here we see the VNS, which is open loop, pre-programmed, extracranial. The main side effects are usually local infection, hoarseness, vocal cord paralysis, and the seizure reduction at 1 year was 26%, and at 5 years was 56%. For RNS, it's closed loop, it's responsive stimulation, it's intracranial, and the main side effects are infection and intracranial hemorrhage. And you see the seizure reduction at 1 year was 44%, and at 2 years was 53%. And for DBS, it's open loop, it's pre-programmed like VNS, but it's intracranial, and the main side effects are infection, intracranial hemorrhage, and you see the seizure reduction from baseline at 1 year was 41%, and at 5 years was 69%. We also have dietary therapies for refractory epilepsy. We have the ketogenic diet, where there's a 4-to-1 or 3-to-1 fat to protein and carbohydrates. We have the medium chain triglyceride diet, which is 1.2 fat to 1 protein and carbohydrates. We have the modified Atkins diet, which is 0.9 to 1, and the low glycemic index diet. So the dietary treatment is indicated for any type of epilepsy. The ketogenic diet is a treatment of choice for certain epileptic encephalopathies like GLUT1 deficiency and myoclonic astatic epilepsy. But the diet is contraindicated in any patients with fatty acid transport problems. So after 6 months, there was a 50 to 60% of the children had a greater than 50% reduction in their seizures. So if the nerve stimulation and the dietary therapies do not work or fail, we have surgical options. We have resective surgery, we have LIT, which is laser interstitial dermal therapy, we have multiple subpile transection, MST, corpus callosotomy, and hemispherectomy. So resective surgery has the best long-term surgical outcome and best prognosis in individuals that have mesotemporal sclerosis. There's an 82% seizure freedom in 12 months, 76% at 24 months, and 64% at 63 months. So better seizure outcome equals a significantly better long-term quality of life. So for extratemporal resection, there's a 25% to 50% seizure freedom. It's most favorable if the outcomes are seen in the occipital parietal region rather than the frontal region, and the better prognosis if the anatomical lesion was identified. So laser interstitial dermal therapy is an MRI-guided laser technology for dermal ablation. It was approved by the FDA in 2010. And this is where laser energy is delivered to the targeted area using a laser applicator, as you see here. As light is delivered through the laser applicator, temperature in the target area begins to rise, destroying the unwanted tissue. The entire procedure is viewed in real time on MR images that shows the dermal maps displaying the distribution of the heat to ensure safety and successful target treatments. So the advantages of the LIT over resective surgery is it's less invasive, there's a shorter procedural time, and a shorter hospital stay. And there's a 30% complete seizure freedom with the LIT, and 67 in patients with MTS, there's a 67% seizure freedom. So multiple subpile transection, or MST, is typically indicated for if the epileptogenic zone is in the dominant eloquent cortex. So this is a disconnection type of procedure that will to avoid resecting the eloquent structure, again, which eloquent zone is a language zone. So about 38% of patients were seizure-free at the 2-year follow-up. And there was 95% reduction of seizures in 87% of patients that had generalized seizures and 68% that had focal seizures. So corpus callosotomy is a surgical division of the corpus callosum. It's either partial anterior, partial posterior, or complete. And the aim is to arrest the propagation of the epileptogenic discharges from one hemisphere to the other. So they found that individuals, like 88% of those who got total corpus callosotomy, had a worthwhile reduction in seizures versus 58 or 59% of patients who underwent interior corpus. So the total ones did better than the ones that had interior corpus callosotomy. And the seizure type that responded the best to it was the drop attacks. So hemispherectomy is either anatomical or functional. So anatomical hemispherectomy is when it's a removal of the frontal, temporal, parietal, and the occipital lobe, and you preserve the thalamus and the basal ganglia. Functional is when you have a disconnection of the lobes with minimum resection. And the seizure freedom ranges from 52 to 80%. And the common complications was hydrocephalus, fever, subdural epidural hematomas, and superficial hemosiderosis. So in conclusion, it's important to classify seizure type before choosing the appropriate ASM. And when choosing a second seizure medication, you want to apply rational polypharmacy. And you want to choose an ASM with another mechanism of action. And you also want to consider other variables when you choose the ASM, like the sex of the patient and the medical comorbidities. So I want to thank the Epilepsy Coalition of New York State and the Epilepsy Foundation of Northeastern New York for allowing me to speak and present during the National Epilepsy Awareness Month, which is in November. And I also want to give special thanks to Dr. Rebecca Spiegel for giving me permission to use some of her slides. So we look forward to seeing you at our live Q&A on November 16th.
Well, that's right now. Thank you so much, Dr. Ning. We're trying to get Dr. Ning's camera on, but we also have Dr. Spiegel on as well, who works really closely with Dr. Ning. So I think that we have Dr. Ning's audio on, just not her camera. So Irene Rogers is going to take some of the questions out of the chat and ask both Dr. Spiegel and Dr. Ning those questions.
Okay. Good afternoon, Dr. Ning. Thank you so much for such a thorough presentation on a lot of complex information. We really appreciate it. And Dr. Spiegel, thank you for being on to field some questions as well. So we have a number of questions. And you may have covered some of these things, Dr. Ning, while you were presenting, but it can't hurt to hear these questions again or the information again, because as I said, it is complex and it's a lot for people to take in. But how does a patient know if their epilepsy is excitatory or inhibitory?
So it's very difficult to really determine whether it's excitatory or inhibitory. But we have a number of things. Mainly, the epilepsy panel can help us really get closer to that, because there are mutations in certain subunits. And that will help us. We know there's certain epilepsy like Dravet's, which is loss of function of the sodium channels. And we have Ohtahara, and that's loss of function of the potassium. So that's and also some of them actually, the mTOR inhibitors, you can't really determine those is not really necessarily excitatory or inhibitory, but that's a very good question. But the best way at this point will be the genetic testing. And Dr. Spiegel, do you have anything to add, Dr. Spiegel?
No, actually, yes. So a lot of them, yeah, with genetic testing, we get better understanding, but unfortunately still, there's a little bit of trial and error in terms of trying to figure things out. But to the most part, many of our patients we don't do genetic testing on. It kind of works out and we find the right therapy on the get-go. And we just follow the basic principles of we either try to reduce the excitation or promote the inhibition. It usually works. But as you pointed out in your wonderful talk, there is a section of patients where we have to have a deeper dive and try to figure out what's going on. Then genetic testings can be helpful, and then try to see what we can do in terms of trying to enhance more either the inhibition or reduce the excitation.
Thank you. What frequency of seizure is considered controlled?
So ideally, we want no seizures. We want our patients to be seizure-free. So controlled is relative to baseline. But in terms of control, as the epileptologist, we want our patients to be seizure-free.
As I'm sure the patients
Right.
would want that.
And Dr. Spiegel, do you have?
No, I agree. Seizure freedom is what we aim for, if at all possible.
So someone had asked about the ketogenic diet. But they were wondering if there were others that is helpful, like keto, for someone that needs carbs because of diabetes type 1.
Right. And so in that case, probably the best diet for that individual would probably be the modified Atkins diet, because it's not as restrictive, right? You still have carbohydrates like bread or even some bakeries, as long as it doesn't exceed the total daily carbohydrate count that be allowable. Like so it's better than keto for that reason, because you can have some carbohydrates. It's not as strict.
That is correct. And I know actually the reason why I accepted the invitation from Dr. Neng is because I'm an adult epileptologist. She's a pediatric. She was actually one of our best fellows we had. She's phenomenal. So it was a pleasure to join. On the adult side, it's very often harder to implement the ketogenic diet because it could be quite restrictive. So we do more of the modified Atkins because it's less restrictive. It's more doable, particularly for our adult patients. So we do that. Although with certain types, for instance, diabetes type 1, it may not be the diet to go as a therapeutic option. It can be very difficult, even with the modified Atkins diet. It could still be restrictive. Sometimes when you get hypoglycemic, you need to take some carbs, which is fine when it comes to type 1 diabetes, but potentially you can actually worsen your epilepsy. The diet is still restrictive. And sometimes when you take carbs, you can actually induce a seizure. So certain things like type 1 in particular, and I saw that in the marks, you may consider not going for any diet restriction of any type, but I mean, in terms of the modified Atkins or the ketogenic. But if you absolutely want to consider that, I absolutely agree. We should go with something like modified Atkins diet, which is less carb restrictive.
Thank you. Are there any updates research updates regarding cannabis for seizure control?
So we have a medication called Epidiolex, which has been approved for like Dravet or Lennox-Gastaut. So definitely like at least a 40% seizure reduction. So there is evidence with Epidiolex, which as an adjunctive.
Thank you. So earlier we heard a presentation from a genetic counselor, and this attendee took from that presentation that it sounds like genetic testing is almost imperative to determine the most appropriate course of action or course of treatment. Is that correct? And if that's not correct, how do doctors really know the right medication?
So the epilepsy panel is an integral part of our workup. And for majority of us, we actually order an epilepsy panel on a majority of our patients. And in terms of knowing which medication works best, it's always like a trial and error. So every patient is different. And that's how we determine, and of course we want to make sure that that we, in terms, before we say that a medication failed, you want to make sure they reach the highest targeted dose. In addition, like my earlier slides, you want to make sure also it's not due to non-compliance on the patient's side. So, and that's how, so everything's trial and error because everyone is made up a little differently.
Thank you. Yeah, it can be a tough answer to hear that there is trial and error.
True, statistics is on our side. That's the good news. When it comes to trial and error. Listen, there is a major development in the world of genetics, even since I started in the field. And actually, as our wonderful geneticist, and it was a pleasure listening to her talk, we do have some specific types of epilepsies where it's been wonderful to know which seizure medications to avoid and which seizure medications to work on, particularly the SCNA forms of mutations. Here it's wonderful, and we're all looking forward to further development. We know it's happening. Every couple of years there's a slew of extra genes that we get better understanding, but unfortunately we're still not where we should be yet. So yes, there is some trial and error as a result. And then what we do is, but we know that typically with one seizure medication, if we diagnose the right type of epilepsy, we have a very good chance, 50% of making people seizure-free. So we are happy there. And then when we have to choose a second medication, in some of our patients, we do exactly what Dr. Deng was mentioning, and we do what we call rational polypharmacy. We look for a different mechanism of action to stop the seizure propagation. So we use those principles, but we are so eager. Genetics has transformed our field, but there is still miles to go through.
Thank you. Oops, I apologize. How do you know if you have intractable epilepsy? I have been on almost every drug except the really new ones.
So we know that individual has intractable epilepsy if they fail greater than 2 ASMs.
If the 2 anti-seizure medications are not effective.
Correct.
Okay.
And we know that 66% will respond to the first 2 ASMs, but there's 33% are intractable or refractory.
If patients are on Topamax and are already on vitamin D deficient, is there a higher risk for osteoporosis when aging, especially for women?
Yes. Big time. Actually, I co-authored several papers on that, so I'm barging here. The answer is yes. First of all, there are some seizure medications, Topamax included, that can cause bone loss actually at any age, incidentally, particularly if you've been in it for a while. Topiramate is on that list, okay? But with that said, God knows it could be an extremely effective medication, so we work through it if needed be. On the adult side, if somebody has been on topiramate for a while, it's fair game to actually do bone density, and we have even young adults who we check that out of ample cautiousness. And we typically supplement with vitamin D. There is also calcium formulations that we also give our patients, recommend for the patients to take with the vitamin D to actually enhance the bone density. There are still lacking studies as to the efficacy of our supplementation, although we have actually with Einstein, my group and Einstein, we've been looking at that, and preliminary does look like when we supplement, very often we can halt progression and oftentimes reverse bone loss. So that's good news. So it's not a contraindication, even if you have vitamin D deficiency. You just have to work on supplementation with your primary care physician, sometimes even a rheumatologist or endocrinologist.
Thank you. There are several more questions, but we are at time. So we will, if I can impose upon Dr. Ning and Dr. Spiegel to perhaps respond to the questions in the chat, And then we will be able to share that with the audience, and that would be so helpful. We don't want to leave anyone out because there are a lot of burning questions. Thank you.
Thank you.
Yes, thanks so much, Dr. Spiegel and Dr. Ning. That was really great. Moving on, we're at the home stretch. Next, we're going to be talking or listening to Colleen Quinn. She's an epilepsy advocate. She is Paul St. Pierre's mom, a namesake of Paul's Law in New Jersey. Colleen has worked with children and adults with autism and other disabilities for over 30 years in a variety of capacities for both private and public schools. Since Paul's diagnosis of epilepsy in February 2019, Colleen has worked tirelessly to create Paul's Law in New Jersey for seizure-safe schools. She has become a dedicated fundraiser and epilepsy advocate, meeting with legislators in the state on national levels to discuss policy relating to epilepsy. So I will play her video now, and we will have a time after the video plays of Colleen speaking to have what's next for us in New York.
Hi, everyone. My name is Colleen Quinn, and I'm here today to talk to you about advocacy. In February of 2019, my son Paul was diagnosed with epilepsy. It took probably 3 months for him to actually get a diagnosis. His seizures started, and they were small and short, thankfully, but over the course from November to February, they progressed to longer, more complex, and several, as many as 5 or 6 within a day. So this is how I basically became involved with the epilepsy community. I'm going to share a little bit about my advocacy story, which links to many different wonderful advocates around the country. So what I've definitely learned is you need to identify what you want to change or create. You need to contact your representative or your senator. Then you need to get your word out, build your base in your community, and then plan your testimony and testify on behalf of the bill. In our case, our first bill that we worked on was Seizure Safe Schools. So in 2019, Paul and I went to our state senator, Jane Beach, and requested that he would do Seizure Safe Schools in New Jersey. We were the 5th state in the country to pass the legislation. It was introduced in September and passed by January of 2020. We met Sherry Dudo from Texas, who was also at the time working on Seizure Safe Schools, and we shared pointers back and forth about how to increase people to help us within our states. We built Facebook pages, did calls to advocacy, worked with the Epilepsy Alliance, the Epilepsy Foundation in our states to pass both laws. We formed Paul's Purple Warriors in 2019 and partnered with Epilepsy Services of New Jersey when we worked on Paul's Law. And in this picture, you can see Paul and I, he's so small there, my best friend Colleen, and our wonderful partner Liza Gundel from Epilepsy Services of New Jersey. As I said, Paul's Law was signed in 2020 by Governor Murphy, making us the 5th state to create seizure safe schools. And that's our senator there along with us. The Texas story was a pretty difficult story. Sherry Dudo, who herself was a teacher with epilepsy, met a family whose daughter passed away from SUDEP. Her name was Samantha Watkins, and they passed in Texas just before us in honor of Samantha, who lost her life to epilepsy. Sam's Law was signed in 2019, making them the 4th state in the nation. We also met Lindsay Crunk from Kentucky. Her daughter, Lindsay, was the Lindsay Crunk Act of Kentucky, and they passed in March of 2019. They were actually the 1st state to do seizure safe schools. Oh, sorry, my bad. signed into law early 2018. It's hard to keep track of all of them, pardon me. So after meeting Lindsay and her mom, Cindy, and meeting Sherry and Barbara, Samantha's mom, we decided that we needed to do something to work across the country to help other people be able to pass seizure-safe school legislation. So I decided we would form the page National Epilepsy Advocates for Seizure-Safe Schools. In the page, we would roll call the states, find people who wanted to work on legislation, put them in touch with advocates in their state, or hook them up with the alliance or the foundation, and we would guide them through. We would get letters of support for them. We'd conduct meetings with them to help them plan and talk to their legislature. And we would basically support them and mentor them throughout the legislative process. We were very blessed in that once we got letters for, our states, that we had a great base of support from organizations all around the country. And we used those letters to help other states. So once we created the Facebook page, we had people from all over the country joining. And in that page, we were blessed enough to find people who were interested and wanted to work on seizure-safe schools. What we told people was basically start your Facebook page, that you're working on seizure-safe school legislation, reach out to your representatives, maybe bring examples of some of the states that have passed. At the time, I think maybe there was 5 states that had passed. You wanted to give your state statistics on, children with epilepsy, if that was the legislation you were working on. So the legislators would know that, like, for example, in New Jersey, we're a tiny state and it's over 12,000 kids. And all these stats are available, obviously, on the CDC's website for each state. And explain, how seizure recognition and first aid training is life-saving. You can get your training free from the Epilepsy Alliance as well as the Epilepsy Foundation. You can get it online or in person. So once you got a commitment from your legislator to work on your legislation, you want to grow your advocacy base using your Facebook page or partnering with your alliance and your foundation, whatever is available to you, or even connecting on our page, the page that we created for people who want to work on seizure-safe school legislation. The formula that worked for us is basically this formula. So we've helped 10 states do it. I believe the Epilepsy Foundation has done it in 13. I think there's 23 states. But this is what we've used in basically every state, and it's been helpful to us. So parents of children who have epilepsy, that's a critical person to testify. If students with epilepsy can also testify, that's a fabulous thing. I was blessed that my son was willing to do it here. And we had some other amazing parents who helped us and testified, and other students with epilepsy who testified. In South Carolina, for example, they just recently passed, and there was a lovely young man, Grayson. He sticks out in my mind because he's a sibling of a child with epilepsy, and he stood up and testified on behalf of his sister. If you could get your child study team director, superintendents, a doctor, of course, the Epilepsy Alliance or the Epilepsy Foundation or any other organizations in your state, that work on behalf of people with epilepsy. In most states, you can send in written testimony. You can show up and testify. They want you to keep it short, like 2 minutes, don't go over. And just express your thoughts and your views, and they listen. And we made a lot of progress across the country, and I'm really proud of this list. And I hope that everyone is on here that has actually helped us. But for the letters that we've sent for the 10 states that we've helped, we've gotten letters from all the organizations that you see here. And also the Honorable Tony Colello. He was a congressman. For those of you who don't know, he was author of the ADA, and he also is a person who has epilepsy. So one of the first states we mentored was Virginia, and that's the Jamie and Bree Strong Act, and that was signed into law in 2021. These ladies were very dedicated and amazing, and it took them a few tries to get it through. Going to play a little clip of the mom and her daughter from Virginia.
Hi everyone, my name is Bree and this is my mom.
Hi, I'm Rowena.
We helped pass the Jamie and Bree Strong Act for seizure-safe schools in Virginia. We were the 6th state to get this law passed.
So our journey began when I connected with Miss Sherry Dudo of Texas and Miss Colleen Quinn of New Jersey. Miss Sherry had already passed Sam's Law in Texas, and Miss Colleen was in the process of passing Paul's Law in New Jersey. They both helped guide us through the process and connected us with some amazing advocates to help us get it started in our state of Virginia. We also learned about the Lindsay Crunk Act and learned more about Cindy and Lindsay Crunk of Kentucky.
I was 11 years old when we met with our local senator and we showed him a copy of Sam's Law and information about Paul's Law.
So I always just say it was a journey filled with blood, sweat, and tears, but it was well worth it because
the Jamie and Bree Strong Act for seizure-safe schools in Virginia was passed in 2021 and was implemented this school year.
So we want to thank all of our amazing advocates who supported us along the way, especially to Miss Sherry Dudo and Miss Colleen Quinn to helping us get it started and also supporting us through the journey. So big thanks, and again to our amazing advocates and our senator and everyone who continues to support the bill all throughout the United States. The goal is to get it through all
50 states.
All 50 states, that's right. So we know with the power of all of our epilepsy warriors, we know that we can get this done, and seizure safe schools will be in every state, right? We're very hopeful for that. So big thanks again to Miss Sherry and to Miss Colleen. They're doing amazing work. Also to Miss Crunk in Kentucky. We want to thank all of you again, and good luck with everything. Best wishes, and we know that we can get this done. Thank you.
Hi everyone, my name.
So another state that worked very hard is Maryland. Maryland was the Breland Act, and that passed in April 7th of 2022. Lauren is the mom's name, and they had a super advocacy base in Maryland. So I'm going to let you hear from Lauren.
Hi everyone, my name is Lauren Schellinger, and our family is from Frederick County, Maryland. The inspiration for our seizure-safe school legislation is our daughter, Brinley. Brinley was born with tuberous sclerosis complex, and she also has epilepsy and autism. And we started working on the bill in 2019, and it was around the time that our daughter was starting preschool. Our biggest champions were our bill sponsors from Frederick County, which was Senator Ronald Young and Delegate Ken Kerr. It was truly a grassroots effort where we worked with many, many families across the state to share their stories, to do action alerts, send emails to contact their legislation. We put in the bill about 3 times through the Maryland General Assembly. We worked with multiple organizations across Maryland and across the United States, including the Seizure Action Plan Coalition, the TSC Alliance, the ARC of Maryland, the Epilepsy Foundation, and many other groups. And a really huge help to us was the National Advocates page. We wanted to thank Colleen, Cindy, and Sherry for all their support, all the families across Maryland that advocated together to get this legislation put forth and then eventually passed. The legislation passed unanimously in both the House and Senate in April of 2022, making Maryland the 15th seizure-safe school state. We're working now on implementation of the bill in Maryland, and it will start this next school year. We're so excited. And we just really encourage everyone to work together until all 50 states have seizure-safe school legislation. And we just hope you have a magical trip. Hi, everyone. My legislation.
So Arizona was another state that was also found from the Seizure Safe School page. So here's a little clip from our friend Brandon in Arizona.
Hi everybody, it's me, Brandon Berry. I wanted to thank Colleen Quinn for allowing me to talk about what we did here in Arizona with Seizure Safe Schools, with the SB 1654, the Georgia Ford bill. I went to my state senator, Senator Kerr, in July of 2019. It was a long process. We started with the legislation in January 2020, and we almost got it passed, but then COVID hit in March and we had to start over again, and it seemed like it was held hostage in 2021, but we went at it again in 2022 of January, and we finally got it passed in April 29th, 2022, and Governor Ducey signed it into law here in Arizona. And, you know, it was a lot of work. Me, Senator Kerr, members of the Epilepsy Foundation of Arizona here, and many advocates across the state here in Arizona who came and testified. And it was a very lengthy process, and it took a lot of hard work, but I, think especially the people on the Seizure Safe Schools Facebook page, Colleen, and many others around the country, and I thank them for their support and everybody involved in SB 1654, the Georgia Ford bill. Hi everybody.
So Missouri, another state that came from the page has been so helpful. I can't, we're really blessed to have the page. We met little Will and his family from Missouri, and we mentored them through the process. And then Holly Brady sort of jumped in out there to help us. She runs the Purple Peace Foundation there, and she lost her daughter to SUDEP. So she was also instrumental in helping out there. And, they worked the process just like we described previously in the earlier slides, and passed Will's Law. Louisiana, we had the pleasure of working with Amanda Mitchell, who is a director in Louisiana for the Epilepsy Alliance, and Amanda's was a joy to work with, and they passed in Louisiana.
Hi, my name's Amanda Mitchell, and I'm the Executive Director for Epilepsy Alliance Louisiana. And always more importantly, I am Jackson's mom. Jackson is my 7-year-old son who has epilepsy. And when I started this work, I was surprised and frustrated to see how many families that would call our office dealing with issues related to schools. We had several families who didn't feel safe sending their kids to school because the schools were unwilling to provide seizure first aid and safety training to the staff. And as a parent of a kid with epilepsy, particularly one who has a history of emergency seizures, it was really important to me to ensure that all kids can go to school safely. And when it was time for Jackson to go to school, we as a family dealt with some of those issues as well. So passing seizure safe school legislation was really important to me. And that would not have happened here in Louisiana without Colleen Quinn and the other advocates that are part of the National Epilepsy Advocates for Seizure Safe Schools. Legislation was not something that I had done before. Advocacy was really new to me. And Colleen was really amazing in helping me to understand the process and what I needed to do to get the legislation passed here in Louisiana. So we are grateful for all of the work that Colleen and the other advocates who are doing this work day over day, and really thank. Hi.
So far, approximately 23 states have passed. When I say that, one state was repealed. I believe that was Indiana was repealed, and There are other states that aren't on this list that are actually in progress. South Carolina is a recent state to pass. In fact, I think they are the most recent state to pass. And that was done by our friends, again, from the page, Lisa Stout and Amanda Lancaster Campbell. There's a little blurb from them.
When my daughter was diagnosed with epilepsy in 2018, I did like most parents. I researched. During my research, I found the National Seizure Safe Schools Facebook page. This page was trying to bring awareness to every state in the U.S. in hopes to have all states pass similar seizure-safe school laws. This is where I met Colleen Quinn, Sherry Dudo, and Cindy Crunk. Since South Carolina did not have an epilepsy foundation or an epilepsy alliance, these ladies assured me they would help me every step of the way if I decided to begin the process in South Carolina. And they have been with me since 2020. Helping guide me through the process. My first step was making a Facebook for South Carolina called South Carolina Advocates for Seizure Safe Schools. We've used this page to help find other advocates in South Carolina. Other states have similar Facebook pages too. We use this page to keep everyone updated during the process and when we need our members to reach out to certain representatives or committees. Colleen, Sherry, and Cindy has helped South Carolina get numerous support letters from different organizations relating to epilepsy that we send straight to our legislators. Sometime last year, the Alliance partnered with SAFE. It's a nonprofit epilepsy awareness organization in South Carolina to bring the Epilepsy Alliance of America to our state. These three ladies helped connect us to the organization where we had much more at our fingertips and a bigger voice. Not only have these three ladies passed seizure-safe school laws in their home state, they are helping several other states with their legislative process. They keep me on my toes, never allowing me to let South Carolina's proposed bill die. Even though my state is not in session, these ladies are helping me behind the scenes to prepare for the upcoming session. If you are currently working on your state or thinking about it, please contact Cindy Crunk, Sherry Dudo, and Colleen Quinn. You will not regret it. They will fight for your state like it's their own. When my daughter
Amanda, she was great to work with. You know, South Carolina, we were lucky that the Alliance did come to that state and did hop in and help, and they were the most recent school to pass. Last but not least is our friend AJ in Georgia. I'm not even sure that bill number is right, to be honest, because Georgia passed, and this slide is a previous slide from when he was working on it. But I know the Facebook is correct, so feel free to go to his Facebook after the presentation. AJ was great to work with. He himself has epilepsy, and he's just an amazing young man and a huge voice for the epilepsy community in Georgia now. Ohio is a member of the Alliance, and I know here they partnered, the Alliance and the Foundation of Ohio partnered together. So here's our friend Doug.
Greetings from the great state of Ohio. My name is Doug Simmons. I'm the Director of Advocacy for Epilepsy Alliance Ohio. I've been asked to share a bit about the progress on seizure-safe legislation in our state. The process began here in Ohio in the summer of 2019 when, after meeting with several state representatives, seizure-safe legislation was drafted, modeled after similar legislation in Indiana, Illinois, Kentucky, North Carolina, and Texas. The bill was named Sarah's Law, after Sarah Leonardis, a young woman who died of SUDEP on Father's Day in June of 2018. The process of getting to committee was painfully slow, due in large part to COVID, but also the fact that the bill did not have bipartisan support despite agreements to the contrary. Unfortunately, the bill had become political. Also at this time, we were encouraged by Colleen Quinn, our new friend in New Jersey, that bipartisan support and a good deal of tenacity was a must in passage of this type of legislation. So in 2021, Epilepsy Alliance Ohio partnered with Epilepsy Foundation of Ohio and together in 2022 provided testimony in the House Primary and Secondary Education Committee from experts, advocates, and caregivers. And on May 25th of 2022, House Bill 606, Sarah's Law for Seizure Safe Schools, unanimously passed the House. We're now anxiously awaiting for the Senate Primary and Secondary Education Committee to take up the bill this fall. Thanks again to Colleen and for her support, as well as for all the other national epilepsy advocates for seizure safe schools who have gone and are going through this process, and for sharing your state stories. Thank you.
In conclusion, I would just like to thank the Epilepsy Coalition of New York State for having me today. And I'd like to thank Sherry and Cindy Crunk for partnering with me on our Facebook page and for being there with me to try to assist some other states to do what we've done. I'd like to dedicate this presentation to Samantha Watkins, Amanda Brady, and Morgan Rose Hashbach, who are children who lost their life to SUDEP.
Thank you so much, Colleen, for that and all those testaments of some of the seizure safe in school efforts across the country. We thought it would be good now to have us talk about our next steps, specifically in New York here. So our staff, Irene Rogers from Long Island, is going to lead us in what those next steps are for New York State in advocacy. Thanks, Irene.
Thank you so much, Mike. So the name of this conference is Empowering People with Epilepsy. But as you can see from today's panel presentation, as well as our keynote, and just most recently, the advocacy presentation, it's really about people with epilepsy, people living with epilepsy, people affected by epilepsy that are empowering one another. I don't know about the rest of you, but I am incredibly inspired and motivated and to take these next steps with advocacy. A lot of times people worry about, what kind of advocate they can be, or, are they a good advocate? And as you can see from the videos that were just shown, it's everyday people, who are living with epilepsy. And the strength comes from our voices joining together, and we're creating change, and we can all be a part of that effort. Everyone in attendance today, people who are diagnosed with epilepsy, family, friends, community stakeholders, in particular, our legislators. So there's a whole network of support. We have the Epilepsy Coalition of New York State, we have the Epilepsy Alliance of America, and the Epilepsy Foundation of America. And the Epilepsy Coalition is made up of a number of agencies that are a part of those alliances. So, moving forward, everyone always wants to know, what do we do now? There was a lot of presentations on the seizure safe schools legislation, which is at a state level. And, almost half of the United States have seizure safe school legislation. So New York needs to be the next one. We need to be on board with that. But there are also other things going on from an advocacy standpoint or legislative standpoint. At the federal level, there's the Congressional Epilepsy Caucus. Both the House and Senate have members who are a part of this caucus. And so we need to get to our representatives, and my light went out, but to reach to our representatives to join the caucus. We also, there's newly introduced act, this Seizure Awareness and Preparedness Act. And that's about grants and funding to provide awareness and education in the schools. So there's a lot going on. So at this point, we're just putting out a call to action. The time is now. So if for those of you at the watch parties, we have the advocacy QR code. We have a survey to find out from people if they would like to be involved with advocacy efforts, to reach out to us and complete the survey. And in addition to at the watch parties, we sent out a reminder about this conference, and in that reminder is a link to the survey. Please, we encourage you to fill it out. And even if you're not certain, but you just want to know more about what these advocacy initiatives are, please complete the survey, and we would love to hear from everyone. Thank you.
Thank you, Irene. And also, we have a couple slides that I wanted to share from Colleen that she passed along to us. So I'm going to do that now. And also, there was a couple questions in the chat about advocacy, participating in recreational activities, and can't participate unless he has an adult companion with him. And rescue has to be called any seizure. So there's a lot of different definitions of advocacy. We have advocacy, legislative advocacy, and then also just having our voices heard and speaking out and letting people know when you need help. And as far as recreational activities, or how to talk to first responders or faculty and staff in school or your employer, a lot of times it's explaining your situation, but only explain what you feel is necessary.
Can I just add something to Mike? Because I see in the chat about the Facebook pages and not seeing anything for New York. So I'll just reiterate, please complete the survey. And that will help us to know what advocacy issues people would like us to address, so that we can work together. The presentation on advocacy was about seizure safe schools legislation. But there are many other advocacy issues regarding children, adults, families. So please, anything that you would like to see being addressed from an advocacy standpoint, you can put that in the survey. I noticed someone else had asked about medications and controlled medications. So please, put that in the survey. And then moving forward, we too will have pages specifically to the advocacy effort on our social media pages.
And also, Colleen's last slide that we're sharing here is a special thanks to all the organizations that have signed on for the Seizure Safe in Schools. So I hope you guys, everyone in attendance today, has enjoyed the content of the conference. And to follow up, we're going to have Janine Garib. She's going to be having our final thoughts and closing message.
Okay. So thank you all so much for joining us here today. I hope you all are leaving as inspired and motivated as I am. I really learned a lot from our fabulous presenters, our doctors, our geneticists, and our individuals with epilepsy who came on today to share their personal stories. I also want to give one final shout out to our two sponsors, Catalyst Pharmaceuticals and SK Life Science. We couldn't do this without your support, so we're very, very grateful for that. And if you live in the Albany area tonight, please take a drive down to the Empire State Plaza. It will be illuminated in purple for epilepsy awareness just tonight, so you have to go down tonight after dark. And if you live in the Rochester area, there are a number of buildings being illuminated tonight and tomorrow night in purple for epilepsy awareness, so check those out. And if you do get out, we would love for you to take pictures, share them on your social media. It'll just help us all build awareness for epilepsy during this special month. In closing, I just want to say that the Epilepsy Coalition of New York State, along with our 6 partner organizations across the state, are here to support you. So if you haven't already connected with us, I hope you will. I hope you will call us first thing Monday morning. We want those phones to be ringing off the hook with all of your questions and ways that we can support you. On behalf of all of us, I thank you so much for being here today. Enjoy the rest of your Saturday, enjoy the weekend, and enjoy your Thanksgiving. Thank you so much.
Thank you and have a good afternoon, everyone.